Ma'am, we are live, you can start.
Okay. Good morning, everyone. A warm welcome on behalf of the organizing committee, and you welcome to the 18th CIGICON 2021 under the aegis of Cochlear Implant Group of India and the 6th World Congress on CI in Emerging Nations under the aegis of Global CI Access Network. We welcome you all, and we will be starting our proceedings immediately. Today's masterclass by Dr. Jane Medell is using speech science and speech perception to manage children with cochlear implants. This is in the rehabilitation stream. Before that, we will introduce Dr. Bhanumati, who is the chairperson for this masterclass. And I welcome Dr. Bhanumati, and I also welcome Dr. Jane Medell. So Dr. N. Bhanumati, she's from Chandigarh, India. She's the Associate Professor, Speech and Hearing Unit in PGI Chandigarh. She's a postdoctorate in speech pathology. She's got 13 years of academics, research and clinical experience. She's a member of various professional bodies and a recipient of many awards, and also has presented papers in both national and international conferences. I heartily welcome you, Dr. Bhanumati, and I hand over the platform to you. Dr. Bhanu?
Can you hear me, Rashmi?
Yes, we can hear you now.
I think there was a network issue. And thank you so much, Rashmi, for having a great introduction. And I'm really glad to have received this opportunity of moderating and opening up the conference today morning for the habilitation session. With such a great person, like internationally recognized expert in pediatric hearing loss and pediatric hearing and spoken language. So I'm really glad to welcome Dr. Jane, who is an audiologist, SLP and LSLS auditory verbal therapist. Her clinical and research interests include, Rashmi, can you please?
Sorry about that. Yeah, sorry about that.
Her clinical and research interests include hearing in infants and children, management of severe to profound hearing loss, and auditory processing disorders. She has also published 7 books, numerous book chapters and articles. She presents nationally and internationally on topics related to hearing loss in children and working with families. She's a recipient of Marion Downs Award for Excellence in Pediatric Audiology and with Irene Taylor Brodsky, which I think all of us don't require any introduction because the Listening Project is a very famous documentary film which came up with 15 hearing impaired adults who were former patients of Dr. Jane. So she has followed them up till the adulthood, and she has given us such a good documentary film. And so we are very proud to have you here, Dr. Jane.
I'm delighted to be here. I can't thank you all enough for inviting me. This is really quite an honor, and I'm sorry that the world is such that we can't travel, because I would really love to be visiting in India. But unfortunately, this is where we are.
We would have been really glad to have you in person and meeting you in person. I'm really glad to welcome you, and it's an honor to have you here for the CIGICON and CIAN 2021. So I welcome you, and I hand over to you for the presentation to go on. You can start your presentation. Over to you.
Thank you very much. I'm happy to do so. I am going to probably talk faster than I should because I thought I was talking for longer than I am, so I'm going to talk quickly and try to get as much in as I can. So the topic is, as you heard, is using speech acoustic and speech perception information to maximize performance. Okay, right now we're having a little problem forwarding the slides. There we go. Okay, good. So, as I think we all know, hearing loss in children is a neurological emergency. It's the most common disability worldwide. And the problem is that hearing loss causes problems for auditory brain development. When a child is born with a hearing loss, that child already has 20 weeks of auditory deprivation because children with typical hearing are born and have been hearing for those 20 weeks. So we need to talk about, audition is the way we develop the auditory part of the brain so that we can use listening to learn. At birth, a child has about 100 billion neurons. And in addition, there are multiple synapses which connect the neurons. But the synapses are not developed at birth. The synapses only become developed as we stimulate a child's brain. And if we stimulate the brain, the child can develop 700 to 1,000 new connections or synapses every second. So every time we talk to a child or laugh with a child or play with a child or sing to a child, we help them grow their brain. And we know that the early years are the most critical for this. And as children grow, their brains start to prune the unused synapses. So time is of the essence. We need to we need to build those synapses as early as possible. Adult brains can have 300 trillion connections, but children's brains can have a quadrillion connections if we provide them with enough stimulation. And this obviously has critical implications for hearing loss because we need to find ways to provide children with stimulation all along as early as possible. Hearing loss is a first-order event for the development of spoken communication and literacy. Anytime we hear the word hearing, we really need to think auditory brain development. And because we need to develop the auditory brain using all of the connections possible. The acoustic accessibility of intelligible speech is the key. It's not enough to just hear speech, it has to be clear. So signal to noise ratio is critical. The speech needs to be sufficiently louder than the noise, or we're not going to be able to get a good connection. And the audiologist is the person who's really responsible for making sure that a child has sufficient brain access and for managing the hearing loss and the technology and also the acoustic environment, because all of those need to be managed for children to be successful. So first, children need to learn to hear. By that, we mean we need to be sure that their brain has access. They need to be hearing the information, which means that the signal has to get in and it needs to be clear. Once the signal gets into the brain, then they can start to pay attention and learn to listen. First, you have to hear, and then you get to learn to listen. And then you get to understand. So unless you can hear the signal and it is clear so that you can understand it, you cannot begin to listen. But once you hear and then understand, you can move on to listening. Once you hear and can listen, you can move on to understanding. I apologize. It's 10:30 at night in the US and it's a little past my good times of communication. Okay, Hart and Risley. Hart and Risley did a study in 1995 in which they looked at a very large number of children, all the children born in Kansas City, Kansas, in a one-year period, and they recorded their vocalizations once a month for about an hour over a period of 3 years. And they learned some important things. They learned that children who heard in a 14-hour day, children who heard 30,000 words had an IQ of 117 by the time they were 3 and a vocabulary of over 1,000 words. Children who heard only 1,750 and 17,500 words had an IQ of 107 and 749 words. Children who heard only about 8,600 words had an IQ of 79 and about 525 words. So it's not just, was someone talking to the child, but how much was someone talking to the child? The more a child heard, not really a surprise when we think about it, but the more words a child heard in a day, the more their vocabulary they had and the higher their IQ. So what we know is that children who have good, appropriate technology, which is providing acoustic accessibility and an enriched auditory exposure, will have good brain development. You can have the best technology, but if you don't have good auditory exposure, you will not have good brain development. And on the other hand, if you don't have good technology, which provides acoustic accessibility, you won't, even if you have the best enriched auditory exposure, you will not get good brain development. So we need acoustic access, which is critical for, I'm trying to hide, there we go, which is critical for understanding what's going on in the world, for getting acoustic development. If technology is not appropriately programmed, a child will not be able to use hearing to develop speech perception skills. It's not enough to get technology on a child's head. We have to make sure it's doing what we intend for it to do. Technology has to be checked daily to make sure it's functioning. It's electronic, it fails, and children are not good reporters of whether something has failed. So we need to do that work for them. And if a child is not making the progress we expect the child to make, which is at the very least 1 year's growth in 1 year's time, then, and if everyone has high expectations and is talking to the child, then we need to suspect the technology first and suspect that the child doesn't have good acoustic accessibility. Malcolm Gladwell reported that it takes 10,000 hours of practice for a child to learn a new skill. Dehaney reported that it takes 20,000 hours of listening as a basis for reading. Pittman reported that children with hearing loss require 3 times the exposure to learn new words and concepts due to the reduced acoustic bandwidth, which is caused by hearing loss. And children with cochlear implants, we know, can develop speech and language similar to their typical hearing peers if they have appropriately programmed technology and if they have an auditory-based therapy program. So what do we need for children to succeed? First, we need early identification, and then early fitting of technology. But the technology has to be appropriate and provide good auditory access. And children need to wear it at least 10 hours a day. Typical children hear 24 hours a day. Children with hearing loss have to hear at least 10 hours a day. If a child wears technology for only 4 hours a day, it will take that child 6 years to hear what a typical child hears in 1 year. That's a significant problem, and we need to recognize it. And if families are having trouble getting their kids to wear technology, we need to give them that kind of information so that they will know that they have to get their children wearing their technology so they have good acoustic output. They need to be in a language-rich environment with a lot of auditory access, auditory therapy with a family involvement, because families have to be the primary therapists for young children. Children need a lot of opportunities to learn. They need to travel to a lot of places, go to the zoo, go to the park, walk down the street and talk about everything that's happening. And they need to be in educational programs that are able and willing to make the necessary adaptations that they need to make to maximize learning. Yes, they have a hearing loss. Yes, they're wearing technology, they're fit with technology, but are they wearing it? How many hours a day are they wearing it? And is the technology doing what it's supposed to do? We cannot ever assume. If we don't test, we don't know. Audiology is not just testing hearing. It's maximizing auditory access so that children can use listening to learn. Pediatric audiology is different than adult audiology, and it has different skills. Audiologists who understand auditory learning can provide much better treatment to children than audiologists who cannot. The primary goal is to maximize auditory learning. And in order to accomplish this, we need to monitor auditory progress. We need to test technology in each ear separately and 2 ears together so we know whether a child has both ears functioning or just one, and we need to know whether there's any distortion caused by putting the 2 ears together. This is a list of the possible things we can do, my recommendations for doing unaided testing, the different tests that we use, and at different ages. So, what does technology need to do to be accessible? A child needs to hear throughout the frequency range. 6,000 and 8,000 hertz really do matter. Missing high frequencies will result in missing significant grammatical markers. Children will miss pluralization and possessives and non-salient morphemes. And they will miss things that are not stressed during the conversation, such as prepositions. And if that happens, they're going to be missing significant language. They also need to be able to hear soft speech. Normal conversation is at around 50 decibels. Soft speech is around 30 to 35 decibels. If a child cannot hear soft speech, they will not hear peers in the classroom. They will not overhear conversation around them. And they will have limited opportunity to have incidental learning. Children learn 90% of what they learn by overhearing it incidentally, not having it taught to them face to face. So if they don't have incidental learning, they will have both reduced language and reduced literacy skills. Mary Pat Moeller reported in some research that she has done from Boys Town, from the Boys Town group, that about 40% of children in a study she did, the outcomes of children with hearing loss study, that about 40% of children fit with hearing aids were underfit, which means they're not getting sufficient acoustic access. That is a scary piece of information. So let's talk for a second about speech intelligibility. We know speech perception is more than hearing the ling sounds or the LMH sounds. Every speech sound in a child's language needs to be audible to them if they are going to develop good language skills. It needs to be audible at typical and at soft conversational levels, up close and at a distance, and in noise. They need to be able to overhear, so they need to hear soft speech because, as I said, 90% of what infants and young children know, they know by overhearing the things around them. Soft speech is critical. This is an audiogram done from the research of David Pascoe. If you're hearing at the B line, at the top of the speech banana, the audiology fruit, then you're going to hear about 90% of what is said. If you're hearing at the C line, which is at the bottom of the speech banana, you're only going to hear 10% of what is said. So if we think soft speech is important, which we do, we need to be sure our children are hearing towards the top of the speech banana. This is from some work that Arthur Boothroyd did that was published in my pediatric audiology textbook. And what he did was he looked at, for each frequency band, each third octave band, where the energy of speech is. And you can see, as we all know, that most of the information is in the middle, but look at how much information is here in the mid frequencies and in the high frequencies. which is, as we know, the most difficult place for children with hearing loss to hear. So our goal is to try to make sure that children are hearing at the top of the speech banana or at what I like to call the speech string bean. These are the formant frequencies or the energy bands for the vowels of English. And vowels, we know, most of their energy is low frequency, except for the E in E's, which has high frequency energy in it. And if you look at the way the vowels are laid out, the red ovals are where the first formant is for each vowel, and the blue squares are where the second formant is for each vowel. And if you can see here that the first formant for oo and e are really in the same place. And if you don't hear the second formants, you won't be able to know whether the word has an oo or an e in it. But if you hear the second formant, you can see that the second formant for oo is very low at about 750 hertz, and the second formant for e is at about 2700 hertz. So it's critical that you have both formants if you're really going to tell the difference between some of the vowel sounds. And here are the energy bands for the consonants. And again, we have the same kind of information. Energy is in 4 bands: low, mid-high, and high. And children need to be able to hear in all 4 bands if they're going to hear all of these consonants. I've circled the consonants that have energy at 4,000 hertz and above. And you can see here that almost half of the consonants in English have energy at 4,000 hertz or above. So if a child is not hearing this information, they are not going to be getting the information from half of the consonants. They will not be able to distinguish mid-energy consonants that have energy in the mid bands, where most of them have energy. They won't be able to distinguish them if we cannot get them to hear the high frequencies. This is another example of the speech string bean with the phonemes written on it, the consonants written on it. And you can see that consonants have energy in multiple places. Zh, for example, has energy in the low frequencies for voicing. It also has energy at about 2,500 hertz, and again has energy at 4,000 hertz. For a child to consistently recognize zh, they need to hear all 3 consonant energy bands. Normal conversation, as I said before, is at around 50 decibels. Soft conversation is at around 35 decibels. If a child's aided thresholds are at 30 decibels, they're going to be hearing soft speech at a very soft level, and it's not going to be possible for them to follow conversation. In order for them to be able to hear soft speech well enough to use it, they've got to be hearing at least 20, 25 decibels. If they're hearing at a louder level than that, they're not going to understand soft speech. So let's talk about audibility versus intelligibility. Audibility is carried by the vowels. Vowels have high energy, but they have low frequency. So most of the energy is between 250 and 500 hertz for vowels. They carry 90% of the power of speech and only 10% of the intelligibility. Intelligibility is the ability to hear clearly enough and identify critical distinctions between the sounds. Consonants have low energy and high frequency. The majority of the energy is between 2,000 and 4,000 hertz, but as I showed you, half of the consonants have energy at 4,000 hertz and above. So while the consonants have low energy and high frequency, they carry 90% of the intelligibility. This is obviously a design flaw, where the information we need to understand speech is very low audibility. So we need to be sure that the technology is correcting for that. So what is the goal of speech perception testing? If the goal, it has to be to compare children to their typical hearing peers, to monitor how well they're doing with their technology, to monitor the treatment over time to make sure that their speech perception skills are improving, and to identify the specific perception errors that children have so we can use that information to modify the technology settings. So how do we determine what tests to use when we're evaluating speech perception tests? We start off, we need to make sure that we have a vocabulary that is appropriate for the child, both cognitively and auditorily. We don't want to use a vocabulary for a 4-year-old to test a 9-year-old who's in a mainstream setting, because it won't give us the information we need about how that child is managing in a mainstream classroom. So when we do diagnostic testing for speech perception, we test with insert earphones at 40 decibels above the pure tone average. When we test functional testing, which is how we test with technology, we want to test them at a typical level, at soft conversational level, and also in competing noise, because we need to know how that child is functioning in every daily listening situation. We also need to pick words that are to pick test stimuli that are appropriate. We want them to be linguistically appropriate, not too easy and not too hard. We also want them to have an appropriate level of complexity. Sentences, while they do provide a lot of information, really are testing a person's top-down skills. They're testing their ability to fill in the blanks. If I say to you, I'm going to the library to get some, you know that the fill-in word there is books. You don't have to hear it. And that's what happens when we use sentences. The hearing impaired child or adult can figure out what the missing word is just because of what they know of language. If they have good language, they'll be able to fill in the blanks. So it may not necessarily be a hearing test. Monosyllabic words are a better way of measuring perception, because those one-syllable words are a more accurate way of measuring perception because there are fewer clues. Even if we're using monosyllabic words, it's very helpful to really score the test using phoneme perception. If I say the word book, and if books with an S on the end of it, and the child says book, I know the child left out the S and didn't hear it. If I say book and the child says boot, the child has confused a ka for a ta. So that tells me what kind of errors a child's making, and I can then go back and try to repair the damage. We can also use nonsense syllables, which will give children no clues at all and make it an even better and more accurate way of being sure we're testing speech perception. Even if you use monosyllabic words, sometimes a child will say, that sounded like woot, but I know that's not a word. So if we're using nonsense syllables, we don't even get into that situation. Joan Hewitt and I have recently developed a new test called the LMH test, which is either the Ling-Maydell-Hewitt test or the low, mid, high frequency test. It's a 10-item screening test that is intended to replace the Ling test. The Ling test, as we all know, uses 6 sounds, ah, ooh, ee, sh, s, mm. We realize that there's no information in the middle there. They've tested vowels and high frequency consonants, and they're not testing the mid frequencies, which are critical for distinguishing consonants. So we have added n, z, j, and so to make this a 10-item test. And here you can see that the the Ling test is testing that the Ling test is testing low frequencies here and testing high frequencies here, but this whole middle range is really not being well tested. So we have added, we want to be sure we're testing in this range to get the information about perception of consonant differences. So we've added j, z, and n. And this is the LMH test, which is available on my website and probably in a bunch of other places. So the Ling test tested detection, which didn't provide good information about voice quality and limited information about the critical mid frequencies. So we felt that the 6 sounds were not complete. So we've moved to the 10 sounds. And what we're thinking of this initially for very young children is just detection. Even for babies with their technology, we can tell, do they alert when we when we say a sound when they've just put on their hearing aids. And once they are consistently detecting, we want to move on to identification. And children who are 12 to 18 months can start to identify the items on the test. And then we move from identification, where they're pointing to the pictures, to imitation, where they repeat back. So we move from a closed set to an open set, from the 10 sounds, then on to phonemes in isolation, and then phonemes in a vowel, consonant, vowel format, and then to standard speech perception tests by audiologists. And we progress from starting with the practitioner doing the evaluation to helping the parents learn to do that. So here is a form that can be used to do the LMH. The phonemes are here, the right ear, left ear, binaural, and with the remote microphone, and here at different distances. And here is the format that we use. The clinician starts off showing the parent how to do detection of the test, and eventually the parent moves on to doing the detection. The clinician moves on to teaching the child identification, and then once the child learns identification, the parent moves on to identification. Then the clinician moves on to imitation of the 10 sounds, and then imitation of all the phonemes, and the parent is moving on one step behind the clinician. And then after we've all gotten on to imitation of the vowel, consonant, vowels stimuli, then the audiologist will do speech perception testing. We want everybody to keep careful records, both parents and clinicians. And we need to know, is the child having trouble hearing sounds does they only hear sounds when they're close? Can they hear at a distance? How great a distance can they hear? Is the child hearing some sounds close and other sounds at a distance? Do they require a change in technology settings? Do they require change in technology, moving to a different hearing aid, or from a hearing aid to a cochlear implant? So in addition to phoneme scoring, we do word scoring. Anytime I do a speech perception test, I'll record on the form, not just whether the child got it right, but if they got it wrong, what was the confusion? If a child if I say boot and the child says book, that child has confused a t and a k. So I'm going to write down k because t for k, because that's what happened there. So what exactly is the child misperceiving? Which phonemes are they misperceiving? And then which frequencies do those phonemes involve? Vowel technology is, if vowels are the problem, there may be too many lows in the technology setting. I know that is a surprise, but sometimes that's what it is. Or it may be that there are not enough lows. If the child's got a lot of low frequency if they're substituting low frequency sounds, maybe they have too much lows. So if the child is confusing bet for bet, or shoe for Sue, we know what the errors are, and then we can look at the format tables and figure out what to do next. So what can we do to change the technology? And once we've changed the technology, therapy should be able to work on improving perception. So we test in difficult conditions because it gives us a much more realistic picture of the child's everyday performance. It helps us make better decisions about performance. It provides better indication of a child's rehab needs. It makes for better educational placement recommendations. It helps us do better research. It helps families have better expectations. And it helps us determine who needs to move on to a CI when. It also may help us understand why a child has language and listening delays. So there are a number of other things which can affect outcomes. If we test in live voice rather than recorded testing, we're likely to get higher scores. If we use tests that are very easy, we're going to get higher scores. If we forget to do phoneme recording, we're not going to get information. If we test in an open set format rather than a closed set format, we're going to get lower scores because it's more difficult from an open field than from a closed set test. We need to know whether children were tested at normal, soft, or loud levels, and were they tested in competing noise. And we want to be sure children are always tested, right technology alone, left technology alone, two together, and then with the FM, because we see very significant differences in performance when we do ears separately. And if one ear is much poorer than the other ear, we need to improve performance in the poorer ear by first changing the technology settings and then having a child practice listening with the poorer ear alone 2 to 3 hours a day, not in school. This is a list of other things which also affect speech perception, things about some of which we have control, some of which we don't. Degree of hearing loss, audiometric contour, how long the child has had a hearing loss, how long it's been profound, whether the child's been wearing technology. Do people expect the child to use technology to listen? What is the child's primary language, and are we testing the child in the child's primary language? What's the etiology of the hearing loss? Are the settings appropriate? And how experienced is the team who's working with the child? This is a test form I use. It's got a lot of open spaces, but if we don't fill them out, we don't get enough information. I want to talk for a minute about scoring tests. I think that we are sometimes too forgiving when we score speech perception tests on children. And this comes from a study we did that we reported in 2011. It's very important that we be honest when we describe speech perception testing scores. Excellent speech perception is 90 to 100%. Good speech perception is 80 to 89%. Fair speech perception is 70 to 79%. And poor speech perception is less than 70%. If a child has a speech perception score of 64%, and I write in my report and I tell the family that the child's speech perception is good, then the family doesn't know, and the clinicians working with the family don't know that this child has something that has to be fixed. If I say that 64% is good, then nobody knows that this child is not succeeding and is going to have trouble hearing in many situations and needs more therapy, needs a technology change, needs something done to fix it. So when we report on performance, we need to be very honest about how a child is hearing. What is the child hearing? How well are they hearing? And be honest about what needs to be done to fix it. Hearing for language learning, we know that the world is auditory. We know that language is learned by listening. We know that incidental learning is critical for language development, and that language development is critical for reading. So we know what we have to do for language learning. For academic learning, we know that classrooms are noisy. There are children in them. They'll always be noisy. We also know that academic learning relies on hearing. If auditory function is not accurate, then language learning will be limited, classroom learning will be limited, literacy will be limited, and socialization will be limited. Socialization depends upon language. For socialization, children need to hear in a noisy place. They need to have the language. Very young children can play without really having a lot of language. But as children get older, they really need the language. They need to be getting the slang and the idioms of the language. By the time a child is 8.5 or 9, the games they play really require that they understand language. They need to pick up on tone of voice. They need to recognize jokes and sarcasm and annoyance. And children with poor auditory skills are more likely to be bullied. So we need to make sure that they have good auditory and language skills, which may help prevent bullying. So what are the auditory factors that affect learning? Hearing, obviously. Speech perception at normal and soft conversational levels in quiet and in noise. Access to auditory information with their technology. The amount of auditory deprivation a child has had, either through hearing loss or through middle ear disease or through auditory processing disorders. Good and constant language modeling. Control of the auditory environment, which includes noise and distance from the person who's talking, and sound sensitivities for children with things like auditory processing disorders. This is my audiological test protocol. Unaided testing under earphones and speech perception at 40 dB above the pure tone average, middle ear testing, otoacoustic emissions testing, functional testing for children without technology in sound field at normal and soft conversation in quiet and in noise, and with technology, testing aided thresholds to see how close they are to the speech banana, which is going to give you information about how they hear soft speech, that's all. But it gives you information about whether they can hear soft speech. Speech perception at normal conversation, right, left, and binaural, at least at soft conversation binaurally, and at normal conversation binaurally. Here's my testing technology recommendations by age. And here is the short list of aided testing. And just for those of you who don't believe you can really do speech perception testing on young children, this is from a study that I did with Ken Botkin and John Wegman at Long Island College Hospital, and if you from children from 3 to 16, and if you look at the word recognition score, the average word recognition score, they were above 90 in all noise conditions, starting at from 3-year-olds all the way up. It's definitely possible to test young children in noise. So let's talk about using speech perception information to improve technology settings. This is the medial consonant test, which originally developed by Richard Tyler at the University of Iowa. All the consonants are listed here with space on the top for the name, the date, what the technology is, and how far you are from the in testing distance. Here's a short list of consonants that Joan Hewitt and I find are the most common consonants to have errors in. And I want to show you a video of a little girl with me doing the medial consonant test. She's just 4 here. She got her cochlear implant about 9 months before. She had been in a country where technology was not available, and she did not get a cochlear implant until she was 3 years, 3 months. Abba.
Abba.
Perfect. Good Ata, ava. Excellent. Ana, apa. Good work. Ama, aga. Okay, I'm not going to show you the whole test because of time, but you get the information. So we do the medial consonant test to test a person's ability to detect and repeat all the phonemes. And we use this information to modify technology settings to improve their perception and to use the information to plan therapy. So these are the errors that this little girl made. And what I've done is I've then gone into the consonant energy band chart and recorded what the energy was for each of the errors. And you can see here, she said, when the word was duh, she said guh. When it was she said ka. When it was what, she said guh. And so I've recorded what the energy is for each of these consonants. And then I will go and change her technology so that then I should be able to repeat all this testing, and we should see the change immediately. And then if I haven't done a good job of repeating it, of correcting it, then I will make some more corrections. And after that, her auditory verbal therapist will work on listening and spoken language with her and continue to improve her skills. So thank you for listening. We're ready for questions. These are my two books from Tima Medical, which are currently available, the Diagnostic Audiology and the Pediatric Casebook. And this is the new book that we expect out in 2022, a book on therapy, audition, and language. And in case you want to know where I am, this is a picture of the Brooklyn Bridge.
Oh, thank you, Dr. Jain. That was an awesome presentation, very elaborate and extensively overloaded with information. I think you have covered almost every factor that you want to talk about: speech perception and speech signs. Definitely spectral cues are very important for the amplitude and frequency discrimination for children who have hearing impairment. And whether they are aided or implanted, we generally have to think about this aspect as soon as we start our rehabilitation. So I have a few questions. I can probably say the first two questions are very important. If we still have time, we can proceed further. You were talking about those children who have these severe to profound hearing loss kids, right?
I'm sorry, say that again. I didn't.
We are talking about children who have the typical hearing loss and not about the associated issues like auditory neuropathy spectrum disorder or auditory processing deficits. So in those children, can we have any research evidences which talks about speech perception assessment or management? How do we go about with this in this special group?
Are you talking about how will we go about management of children with auditory neuropathy disorder?
With respect to speech perception, how do we assess and how?
Exactly the same thing that we do for a child with the sensory neural hearing loss. There is no difference we need to diagnose it. We know we will know what's doing, and then we'll make a decision about whether the child needs a cochlear implant, depending on what their speech perception is like when they are listening with hearing aids or open ears. But the testing is exactly the same for both of those populations. For children with auditory processing disorders, I'm not particularly looking at that as much as I do for a child with a hearing loss, but I do look at it and then use that information to do auditory therapy.
That's great. So I do have another question with respect to the older prelinguals, because not every country actually has a cakewalk with the younger implantees. So we do have children who are older prelinguals, say, I don't know what is the definition in your country for older prelinguals. We don't have a standard definition, but we do have children who are implanted beyond 5 years, 6 years. And when we talk about the appropriate assessment tool for these children, when we start assessing the speech perception, it becomes a challenging task for the rehabilitationist. So do you have any opinions for that?
I think that we can still use the same kinds of material, just they will start at a lower level, but they should still be able to learn to repeat the sounds that they're hearing. They will be in a different place. But I think of these kids as, in the new textbook that I'm writing, we wrote a chapter in which we called "Late to the Party." These are the children who are coming late, and what we need to think of them as babies. They're listening babies. The games we may use, maybe not baby games because they would be bored with that, but the auditory activities are exactly what we would use on very young children. That does not change.
Yes. So would you suggest that, the monosyllabic, or even say the syllabic presentations, what we do in the phonemically balanced assessments, can we use those also for these kids? Because when we think of the hearing age, it's going to be very less compared to, the children who are implanted earlier. So even that would be best.
So when I spoke very quickly about this, but when we talk about providing children using words that have their cognitive vocabulary. So a child who is implanted late, who is late to the party, will have a lower cognitive cognitive language. Yes. And so we will use the test that is appropriate for that child's cognitive level.
Wonderful.
Does that make sense?
Yes, it does. It does.
Good.
And I really loved your LMH test battery. I think we need to start doing that all over the world, that, it's not just the link sounds, and you have come up with such beautiful frequency band analysis for these tests, and you have compared both. And definitely it gives you a lot of evidence, like, for all the clinicians, that yes, we have to go about the LMS test battery from now on. And it's really lovely to see that.
Well, it has been, I know that it's already been, there are people in Vietnam who are using it now, and also people in the Spanish speaking countries there, they've translated it. So, I mean, more and more countries are going to do that. My language skills are such that I can't be the person who's responsible for finding the words.
That's like really a great tool that you have given us. And I have last question for you with respect to multilingual children. So I think even in your country, you do have multilingual
many.
Yes. So we did have a World Cafe, and we had a big, great discussion on this, and we were literally trying to formulate some guidelines for these children. So would you have any suggestions for these kids for assessing their speech perception abilities and acoustic aspects? How do you assess these kids?
We try to assess them in both languages. We try to assess, what is their primary language? We try to find out from talking to the families, what's the primary language? And we try to assess the children in the primary language.
Okay.
And but then we will also test the children in a secondary language. For example, in the United States, there are many children who have a home language, which really is their first language, and then they have English in school. So they need to be tested in both languages, because we need to know what their speech perception is in their home language, so we know how they're learning language. And we encourage parents to continue to talk to children in the language that they know best, so that their children will have exposure to as much of a rich language exposure as possible. And then for children who are, for the children who are getting English at home, at school, we would want to test them in English also, because we want to know how they're going to manage in a school setting.
Okay, that's interesting. Even we do that in India. I know there's so many languages, and but it's quite a tough thing in India, because we have so many languages. Language specific assessment tools becomes, we really warrant actually to develop so many tools which are language specific. Most of the times it's quite a tough job, because for the primary language, not every child's primary language, we do have an assessment tool. So we do have some informal assessments going on, and I think we are in need of developing these tools.
And that's what you have to do. That you have no choice. You have to use what you have.
Yes, that's true. So that was a great presentation, Dr. Jain, and it was a pleasure having you here, and it was very informative. I'm sure nobody can disagree on this. Rashmi, you can give your take on this.
Okay, thank you so much.
Dr. Jain, thank you so much. That was a very lucid presentation, and I'm sure it will help a lot of people. So thank you so much.
Thank you.
I know it was a very inconvenient timing for you, and we do appreciate.
But I've managed to be awake. I was telling everybody before we got started that I'm usually asleep by 10:30 when I started to present today. So, but I mean, it's a topic that I love talking about. So I got excited and I'm wide awake. So thank you again so much for inviting me, and I'm looking forward to next week when I am more awake, listening to all the presentations that are going to take place during the night tonight and the next couple of days, so that I can listen to them during the daytime. Thank you again so much.
Thank you, Dr. Jain.
Bye-bye.
Thank you, Rashmi.
Bye. Thank you, Banu.
Thank you.
And Shani, I will listen to you next week.
Thanks, Jane. A lot of your topics are the same as I'm going to be covering, so they dovetail in perfectly.
Oh, terrific. Great. I'm sorry I'm not going to stay awake, but I'm not going to.
Happy dreams.
After that wonderful session, we'll be moving on to the next masterclass, which is Current Trends and Future Directions in Research in Rehabilitation of Children with Cochlear Implants. This is by Dr. Shani Detman. And we have a wonderful chairperson also over here, Ms. Shefali Shah. I will just introduce her and then hand over the platform to both of them. So Shefali Shah is dividing her time between UK and India. She has set up Sound Steps, which is an early intervention service which offers face-to-face therapy. Just give me a minute for sharing the screen. Sorry about that. So sorry. So it offers face-to-face therapy exclusively for babies and young children with hearing loss, and also offers an entirely online auditory verbal therapy service via AVT Direct. She represents India in the latest book on AV therapy, auditory verbal therapy for young children in hearing loss and their families and the professionals who guide them, which was published in 2016. She's contributed to foreign publications on AVT. She was also invited to write a monograph on AVT by the Indian Speech and Hearing Association in 2013. She has pioneered a one-year teacher training course in AVT accredited by the Rehabilitation Council of India and the A.G. Bell Academy, USA. So we welcome Shefali Shah, and we also welcome Dr. Shani Detman. I do hand over the platform to you, Shefali, so you can now introduce Dr. Shani, and she can then enthrall us with her presentation.
Hello, everybody. I'm absolutely delighted to welcome Dr. Shani Detman to the 6th World Congress of the Cochlear Implants in Emerging Nations and the 18th National Conference of the Cochlear Implant Group of India. Now, this slide of Dr. Shani Detman is extremely a summarized version of what this lady has done. I mean, literally, she's done everything. Dr. Detman started out as being a speech pathologist, went on to doing her master's and got the LSLS certification, and then, of course, finally a PhD. But her primary area of interest has always been the influence of maternal input and its relationship on the development of long-term communication, spoken language communication skills in young children, with a primary focus on the efficacy of cochlear implantation in infants. So she is just like the perfect speaker to have. She's done it all. I mean, contributed chapters to 5 books, 51 journals, over 200 presentations nationally and globally. So before I hand over to you, Dr. Detman, just a housekeeping note, do keep your questions coming in via the chat, and I'll do my best to get them to Dr. Detman after the presentation. But with that, the screen is all yours.
Thank you very much for that invitation. I'll just share screens and get my first slide. And I'll just get confirmation that you should be able to see my cursor running around on my opening slide there.
Yes, we are able to see your slide and it's wonderfully shared. No problem.
Great, wonderful. So thank you very much for the invitation to speak and also for the introduction. I do have many decades of experience of working with young children and families, and now much more involved with the university in as a senior lecturer position. So teaching the up and coming audiologists and speech pathologists at the University of Melbourne. So this is a very big job to talk about current trends. So I've narrowed it down to just three trends I'm going to focus on, and those are earlier access to hearing. That's of course my specialty area, and I have a lot of publications in that area that I want to take you through. The second trend is unpacking parental input, and both of these topics dovetail in perfectly to the talk that we just heard from Jane Medell. So it's lovely to follow Jane in the conference today. And my third theme or trend is data logging and language tracking, which is all about collecting data. So I'll move on very quickly, and I'll probably talk quite quickly, and I'm very happy to invite persons to email me if there's any of these papers or things that you want to talk about a little bit further. If I have time, I also have some future trends at the end of my slides. So first one, earlier access to hearing, and you've got a little image there, an icon of the brain, and Jane Medell in the talk just before me also spoke a lot about brain development. So the first year of life is crucial for babies with typical hearing. Their caregivers and the babies co-construct a communication foundation. It consists of gaze patterns, vocalizations, and gestures, and it's highly dynamic. It's mutually reinforcing, mutually meaning it's reinforcing to the child and to the mother, and it's synchronous, these highly responsive interactions. So that's the hearing child. And the Joint Committee on Infant Hearing says for children with hearing loss that we must find out and detect, diagnose their hearing loss by at least 1 month of age. They should have hearing aids fitted by 3 months of age, and enrolment into early intervention services by 6 months of age. That's the Joint Committee guidelines of early hearing detection and intervention, the EHDI guidelines. And I've added in yellow there that you should have cochlear implants by 6 to 9 months of age, no later than 12 months of age. And we'll look at the evidence to why I might be saying that. So babies who are deaf and hard of hearing and have those hearing aids fitted in the Joint Committee guidelines at 3 months, they're already greater than 3 months behind their peers because they've missed out on in utero hearing, and then they've had those 3 months of life without their hearing aids. So they're already behind their typical hearing peers in beginning their language acquisition journey. What about cochlear implant kiddies? Okay, so the kids who have profound hearing loss, they're even further behind because surgery typically doesn't occur until after 6 months of age. And you might be in your different centres listening to this saying that cochlear implant surgery doesn't happen at 6 months, it happens at 2 years in your centre or at 18 months at your centre. Okay, so just think about how much the child has already missed. The overview of the next few slides to talking about my first trend, which is earlier access to hearing. I'm going to talk about speech perception and language outcomes. I'm going to talk about some long-term literacy outcomes. I'm going to look at language in a different way by talking about trajectories. I'm going to talk just quickly one slide from Markman on cascading consequences. Another slide there which talks about the brain and making up for lost time. So that's just an overview slide now of what's coming up. This is our multi-centre paper. So we had a great job, and this is big data. So you can see just for this slide alone, we had 125 children in this study. Jane Medell in the talk just before me talked at length about what speech perception tests are like. And this is one where we've got the sounds along the bottom here, the word score along the bottom, and sentence scores along the bottom here as well. What I want to show you is the different groupings. So babies who had an implant younger than 12 months are the triangles, and they're group 1. So keep an eye out for those. And then you've got the other groups between 13, 18 months, and so on and so on. What we saw is our babies in this speech perception material were significantly better scores, significantly better speech perception scores than all the other groups. Okay, so it looks a bit like this. It sort of jumps down. Significantly better scores for groups 1 and 2 if you had an implant under 18 months compared to if you had an implant later. So along here we've got groups 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. We also saw that pattern with sentences, but in a slightly different way. So overall, this is consistent with Anu Sharma. Okay, so her study, very well cited and cited by me in every paper that I write, basically implanted children do best if they have the shortest period of auditory deprivation. So the brain has the least period of auditory deprivation. And in Sharma's study, it's very much that the children who had access to hearing before, or at least by 3.5 years or less, had appropriate latency responses. So we're talking about a sensitive period for listening. And that sounds a bit consistent to our result. Our speech perception result that I just showed you suggested that it's okay to go ahead with an implant up to maybe 18 months for speech perception. So getting that first implant before 18 months would seem to be adequate for speech perception. But we all know, and I hope you're sitting there shaking your head saying speech perception is not enough. What about language? Language is key. That's what we want. So let's look at the language from our, once again, it's our multi-center study. Once again, you're looking out for the little triangles, and that's the bubbies who had an implant younger than 12 months of age. So they're highlighted there with the little red box. And I'll just give you the layout of this slide. It's a language outcome. 100 is normal, and the range for normal is plus or minus 15 standard deviations. So that's shown in the bars there. And what we can see is our bubbies in the triangles, the ones who had an implant younger than 12 months, are in the normal range. In fact, 80% of this group have language abilities in the normal range, which is just absolutely fantastic. In language, it did matter if you had an implant younger than 12 months. So group 1 was significantly different to groups 2, 3, 4, and 5. And you can see that in the data going from our triangle babies down to those who had the implant, if you like, as toddlers between 13, 18 months. And this is 19 months onwards, 25 months, and 43 months for the different groups. So it's pretty convincing evidence that there's something special about hearing in your first year of life. Additionally, groups 1 and 2 were significantly better than 3, 4, 5. So it says, certainly to me, in this big study of over 200 children, that you need access to hearing before 12 months of age. Now, our more recent study in 2021, it was lockdown and I had nothing to do but sit and write papers, yes. So we wrote this paper that went backwards and forwards a couple of times to JSHLR, and I'm very proud of this paper, and it's new. Certainly ask me for a copy, I'm happy to share. Now we're putting the magnifying glass on under 9 months, not just under 12 months, but under 9 months, and asking the question, is there any added value to going ahead under 9 months? I don't know about your different centres. I don't know if it's hard to get even under 18 months or under 12 months in your centres. But on average, the Cochlear Implant Clinic in Melbourne, the average age of implant is now 11 months. So we're interested, is it worth really making that push? Is there added value if we can go ahead under 9 months? So the divisions here in the groupings, the 1, 2, 3, 4, 5, 6, 7 are slightly different to the slides I just showed you. Just keep an eye out for that. And we found 2 factors, age at implant and cognition, were significantly associated with language outcomes. On the axis here, if we have a look at the y-axis, we've got the CLIP. The CLIP stands for Categories of Linguistic Performance. And what we've done is pool a whole lot of data on lots of different language tests. The group before at this conference was saying how different centres have to invent different tools for different languages. Well, that also happens in Australia. We have different centres using lots of different language tests. So with the CLIP, we came up with a system where we can just pool everything. It doesn't matter if this child's had a Minnesota CDI or a Rossetti or a PLS or a Peabody, all these different language tests. We put them all together and we invented the CLIP, or Categories of Linguistic Performance. So a normal range is these bars here again, and I'll just do a little animation to highlight that. So it should be showing in pink. So between 4 and 6 is normal language that we would see with children with normal hearing and typical development. So what we can see here is our bubbies, the ones who had an implant under 9 months, are fully in that normal range, which is lovely to see. You can see the red tracking down, and the red includes children who have no additional cognitive needs. These children do not require support for cognition. They have very within the normal range of cognitive abilities. The grey that you can see on this slide is the children who need support for cognition. Okay, so anything from borderline, low average, through to intellectual disability. An incidental finding in this paper was that there was no children that had a requirement for cognitive support who went ahead under 9 months. And that was just, we didn't know we were going to find that, but you can see the grey bar is missing from these youngest children. There weren't any children who went ahead with an implant under 9 months who had a requirement for cognitive support. And I think in the paper we talk about the reasons that that might be happening. There's lots of other things going on and it's a little more difficult to test these children. But anyway, I'll also point out big numbers. So 362, this is big data. And I really urge the centres that where you all are is to get together and have pooling of data to answer some of these questions. So overall, kiddies having an implant under 9 months, significant language benefit compared to 9 to 12 months, 13 months, and so on. So my next slides are just about literacy. So I don't have as big numbers for this because I had to fly all over Australia and capture these children and test them. It took about 2 or 3 hours of testing, and I typically went into their homes. So I only have 25 in this study, but I'm still very proud of these work. This is the Woodcock Reading Mastery Test. 25 children who had the implant super young. They were under 1 year of age, and a couple of them were under 18 months of age. So, but they had them 18 years ago, 10 years ago. So we're talking about long-term literacy. So whilst they had their implants as when they were bubbies, they are now big teenagers, adolescents. So what we're seeing is all the different subtests of the Woodcock Reading Mastery Test, and you can see the average and the range of scores. I'll just orient you again with my pink bars. So this is the normal range for children with typical development and normal hearing. And here's our kiddies with cochlear implants right in the middle of normal. There's a couple of outliers on a couple of tests, but equally there's outliers way above the average as well. And just because same data, but just represented differently, here's the individual 25 children, and you can see how those means were derived. So that's the Woodcock Reading Mastery Test. This next one is the CTOP, which is a comprehensive test of phonological processing. So a whole range of subtests that I put these children through, doing all this nasty testing on them. And you can see once again the normal range highlighted in the pink and the individual scores on the CTOP. So there's our 25 children completing all of those materials. And finally, in this study, we looked at writing. So in this, the child is given a picture like this one and about 5 minutes to plan a narrative. So they sit there and write me a narrative story. It's scored for how many conventions are correct, like, you know, capitals and full stops and commas and punctuation. but it's also scored for the story and how interesting it is and how it flows, which is a bit subjective. So I had 2 people score this, and we checked our scoring reliability. You can see the same data just represented 2 different ways. We've got the average scores in writing, and I think you can see that they're well above average in the TOWL. This is test of written language, spontaneous narrative, and we've got their individual scores on the left of the screen. So wonderful long-term literacy results. And what I'm basically saying is that these kids are completely within the normal range. So this is what can happen when a child receives an implant and has optimum input right from the word go. So that lovely auditory brain development. So here's a different way of looking at it. Instead of just testing the child once, let's do a whole lot of tests over time. So we develop a trajectory, and this is more accurate for the child's function over time. I'll give you an example here. So we've got perhaps the child does the Minnesota CDR when they're a little tiny bubby, which is a checklist you do with the parents. Then perhaps they do the Rossetti infant toddler language scales. A bit later on, they might do the PLS, preschool language scale. And perhaps when they're 7 or 8, they do the Peabody picture vocabulary test. What are we going to do with all those different tests? We put them together and we derive a trajectory. There's just 6 children in this example, but I'm just giving it as an example. And we can already see the difference between the blue circle child, who has a trajectory along here of 0.74, compared to our purple child. The purple child has a trajectory of 1.24. And just to remind you, normal is 1, okay? So for every 1 year of one calendar year, or every 1 year of growth, you should have 1 year of language growth. So the magic number 1 is what we're looking for. That's just my examples, because this is what 460 receptive language trajectories looks like. It's rather messy, but we're quite proud of the fact that we've got 460 individual children. They were tested on average 4 times. And some of the children were only tested twice. Some of the children were tested 14 times over the course of their management. So we put all of that data together. I'll just remind you again of what that dashed black line means, because you're going to see it in the next few slides. And it's the magic number 1, okay? A normal growth of 1 year of language per calendar year. There's our black line there, just showing you and reminding you again. And in these data, the average was 0.81. So this is all children. We didn't exclude any children who had learning problems or cognitive problems or any other issues that would have stopped them from doing these materials. So everybody that had available data was included in this study, so 460. So 0.81, it's not the magic number 1, but it's a pretty good score. And trajectories ranged from minus 0.22, which basically means the child is making no language growth, right to 2.34, where the child is doubling language growth in 1 year. So 0.81 is pretty good. But let's look at that dashed line now for the factors. So using receptive language trajectory as our outcome, what factors are associated with that? And we've got the list here on the left: cognition, the presence of an additional disability, the etiology of hearing loss, the age at first implant comes up, that's my favourite topic, socioeconomic advantage, the home communication approach, and the mother's education were all significantly associated with the trajectory of language growth in the child. I've just got 3 to highlight for you, and this paper is currently under review. It's been with the reviewers for 3 months, so I'm still waiting to hear. Here's cognition, the first one. So basically we have children with normal cognitive abilities in the normal range, and that's the biggest group, 235, and their average receptive language growth is 0.88, nearly the magic number 1. The next group is children with borderline and low average cognitive abilities. There's 41 of those children, and their receptive language trajectory drops down to 0.70. And in the final group, it's a small group of 38, we have children with less than 70 IQ, so they have a diagnosed additional disability, an intellectual disability. And I think you can see that there's significant differences in the slope between the three groups. There's our line out of the way, and you'll see that line again in the next slide. This one is now age at implant. So we have our bubbies who have an implant between 3 months and 12 months in the Melbourne program, and there's 98 of those. The next group is 13 to 18 months, 19 to 24, and 24 to 42. Once again, significant differences in the slope. So the bubbies nearly achieved the magic number 1, and their slope is 0.97, which is shown here. And the other factor that I just highlight is communication approach chosen by the parents and used in the home. The home communication is sign on the far left, sign and speech. Speech and sign, it's just a degree of emphasis there. Oral approaches, which is our biggest group, and auditory verbal, which is 22. We have significant differences. So the children in auditory verbal programs have significantly better receptive language trajectories than the children in the other signing groups, these three here that have any degree of sign associated with their program. So I always like to show Markman. I love this paper. I'm happy to share it with you. It comes from a great centre and collection of researchers there. And Markman, I think it's a he, just assumed that, Markman gives a great demonstration of the multiple influences on the child. So do read this paper, that the baby starts out with innate abilities, and to some extent it's genetics, but it's these multiple behavioural influences, one of which is hearing. Another one is your role as a habilitationist working with that family. And these things interact to have the child's expression of his language learning potential. Another quick slide from Markman. There are certain stages of neurodevelopment, and these set the stage for time-sensitive readiness for learning based on perception. So a lot of these ideas dovetail in very nicely from Jane's talk that was just before mine today. So Markman talks about amenability to experience-driven change. All right, so the learning of the child contributes to the structure and the complexity of the brain. So learning contributes to brain development. And finally, I always like to include Carol Flexer. There's some great links there, and she's a great presenter, and it's all about the brain. So just to highlight those links and resources are very, very worthwhile looking at. My last point on this trend or towards early hearing is making up for lost time. So it's a bit of a maths problem for you. If the child with normal hearing is listening 24/7 really, but let's take away the time that they're in bed and they're asleep. So 12 hours a day, the typical child is listening. That's 4,380 hours of listening in a year. And that's 26,000 hours of listening in 6 years. So I've got my 6-year-old on my axis here. What if you only have the implant or the hearing aid on your head for 2 hours a day? Well, that's only 730 hours of listening in 1 year. You and your brain has missed 3,560 hours of listening. How are you going to catch that up in 1 year? And if you times that by 6 for the 6-year-old, the child has missed 21,900 hours of listening. So my point here is, how are you going to make up that lost time? If the device is only on the child's head 2 hours a day, you're never going to make up that lost time. So start early and wear the device every waking moment, even when they're asleep. The same thing goes for sign language. What if the child is exposed to the equivalent of only about 2 hours of sign in the day? Well, you're never going to make up that gap. My next trend, I'll just finish off the summary here. So overall, Evidence supports communication outcomes, language and speech perception, but especially language, if babies go ahead with implants under 12 months, and there is added value to going ahead under 9 months. You can make a difference with early aiding and early implants. As Markman says, there are cascading consequences. And as Carol Flexer says, you're building upon building for that consolidation of the child's skills for brain development, and that final sort of idea of making up for lost time. So you've got to start early. All right, overall, our series of studies supported provision of cochlear implants before 9 months of age. Before 9 months for optimum brain language brain to develop. All right, I should check my timing here. I've got my clock. Yes, going well. And move to my second trend. The second trend is a little luggage there for unpacking parental input. This is an overview of the next few slides, which is immersion, play, child participation, and parental participation, and ending with coaching. So as we said before, the early hearing detection and intervention principles we already covered, numbers 1, 2, and 3, which is screening, fitting, and enrolling into EI. So I want to focus on principle number 4, that there's lots of other principles, but here's one that you might not have seen quite as often. Early intervention needs to be family-centred, rights and privacy guaranteed through informed choice, shared decision-making with the parent, and parental consent in accordance with your local guidelines. Parents need access to really good and clear information about all sorts of different intervention and treatment options. That's your family-centred approach. Parents are the key. They are the architects of that baby's brain, and they are the source of natural models of language, abundant models, all day, every day, talking with the child. Parents need our help and support to aid the child and optimise that meaningful communication. So I want you to think about how you learnt language. How did you learn your first language? Well, you can't remember. It was before you were 5. At best, perhaps you can imagine when you learnt a second or a third language. What did you need? You needed to be completely immersed in that language, be around people who are really good models of that language. Best if you did it at a sensitive period of brain development before puberty, and you had to be motivated to communicate. And some of these ideas were spoken about by Sue Archbold at a conference in Melbourne. And so I'm borrowing some of her words here. The child needs exposure to abundant spoken language, quantity and quality. Same thing goes for sign. If you're going to choose to use sign language, it needs to be abundant, quantity and quality. Language opportunities and accessible language, it's got to be fun and meaningful for the child. And the model of that language has to be competent user of that language. So once again, if you choose sign, the mother or the person who's teaching that child listening and language has to be proficient in that language. So we had a look at the Gears and Brenner home activities questionnaire, and you ask the parents, how many times does the child come on errands or have friends over to play or do some hobbies with you or go to the library, family outings, things like that. And you can give it a score from often, weekly, monthly, rarely, never, or not applicable. We added those up and we came up with a percentage correct, or not percentage correct, but a percentage of involvement in family activities. So if the mother said, yes, we do that all the time to all of the 9 items, you'd get 45, 5 times 45, then you convert that to percentage, you get 100%. All right. We put this on this axis. So the family's involvement into family's activities as a percent. So having a look along the x-axis. And on the y-axis, once again, we've got language as our outcome. We've got the Peabody Picture Vocabulary Test, which is just receptive vocabulary, and we've also got the PLS, the Preschool Language Scale tests receptive and expressive language. So that's the different coloured dots there of the grey and the circle and the black. what we see is a significant relationship between the child's involvement in family activities and the language score. So what might happen if the parents are trying to involve the child in everyday activities, but the child has not only hearing loss, but an additional diagnosis? Well, we found quite a different profile for those children. When the child has an additional special need, such as autism or additional learning disability, participation in everyday activity goes from often to sometimes to never. So we saw that difference in the profiles. So what can you do about it? Help parents see the importance of play and family activities and reading. There might be much more pressing things like getting the shopping done or getting the washing done, but they have to see the importance of that input to the child. Reduce screen time. There's more and more evidence about reducing screen time, and see if there's other community or family supports that can pick up other roles so that the parent can be with the child. My next question is, the child, I'm saying this from the point of view of the mother perhaps, my child has a hearing loss. I should limit what I say to her, right? She can't hear me talking, so I should just keep the language simple and short, right? Let's look at that. My interest in this area started way back in 1990 when I heard the mother of this gorgeous child sitting in the waiting room. And the mother was saying in a quiet sort of voice to her child, who had a profound to total hearing loss. At that point, she had hearing aids. The mother was saying, oh, first we're going to pick up your brother Lockie, and then we're going to go and do a bit of shopping. I've got to get some things for tonight, and then we'll go visit grandma. So she's like, blah, 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 blah. There was a lot of language. And I thought all of that language was going straight over the child's head. But I'm happy to say I was wrong. When the mother is doing that, she's providing the sounds and the character of the language. She's providing the weighted phonology of the language. So what sounds carry meaning, whether it's tonal language or a non-tonal language, whether the sh makes a difference, whether the s on the ends of words makes a difference, whether it's 2 syllables or 3 syllable words, those sorts of things are the phonology of that language. And she's also providing the opportunity for the child to extract out keywords for herself. So if the mother said, oh, we're going to go and pick up Lockie, blah, 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 and then we're going to do this, blah, 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 the child gets to hear Lockie. Okay, Lockie's my brother's name. I can pull that word out from that great auditory stream. So let's look at mother's length of utterance to normal hearing children. And each one of these black boxes is a study, and I've read them all, so you don't have to. And I've overlaid a bit of an orange line here to suggest that we talk with very long utterances as soon as the baby is born. We talk in very long, oh, aren't you a lovely baby? Would you like your bottle now? You're just a beautiful baby. All right. But we drop down to short utterances when the child is ready to say his first words. So following that, rough orange line there. It drops down in the length of utterance, and then it follows along as the child's language develops. So this gives you a rough idea of the mother's fine-tuning and fitting in with the child's abilities. What happens that is significant is that the child, before they could walk and talk, before they were a moving, crawling baby, they were a captive audience. And that baby got to hear the character of the language, the phonology of the language. That baby who couldn't crawl away yet got to hear all of the natural sounds of the language. What about hearing loss? So the triangles here are some other studies where the child has hearing aids, and you can see basically that it's dropped down quite shorter utterances. So mothers talk to children with hearing aids as if they're a much younger child. So let's just take one of these studies. The child is 7 years of age, but if we follow that triangle back, it's like the mother's talking to the child as if it was a 3-year-old. And what about cochlear implant kiddies? So this is in the mother's length of utterance, both in morphemes and in words. And we see this lovely matching. It gets longer as the child gets older, But what I want to point out is what is missing. So I think if I give you a second to catch up with my slides, it's here. That lovely immersion of the child in the natural character and phonology is missing. Parents with cochlear implants started out with short bits, short utterances. And I think there's something definitely missing there, that parents need to be encouraged to use both long and short. Van Normalinga did a great study where they had 25 children with normal hearing and 9 children using cochlear implants. The mothers of the normal hearing children used longer utterances with shorter duration. Okay, so they're talking more quickly. They also produced more turns with their normal hearing children. And not only that, they got faster over time. So their utterances were longer and got faster and faster and faster. And I think that's a fantastic thing, because it means that the mothers are training up the child's brain to keep up with that faster and faster verbal processing. You think about the opposite. What do? We think the child can't understand us or can't hear us because they've got a cochlear implant, and we break it down to simple language, transactional language. We're just getting the minimum through. I think that's a bad idea, and we need to encourage parents to use long utterances, long singing, long nursery rhymes. Some of it is going way over the child's head, but also you're letting the child hear the character, the phonology of that language. So Jane also talked about Hart and Risley in the amount of input that is to the child. Many of you will have seen this, and I hope you've followed along with the 30 million word literature. In short, children who were from professional families heard about 50 million words by the time the child was 4 years of age. But children who were from what were Hart and Risley called welfare families only heard about 15 million words by the time the child was 4 years of age. So this was very significant data. It was old school, by the way. They had to go into the homes with notepads. They didn't have very many recording devices, and they just basically pages and pages, thousands of pages of notes, which they used to collect these data. What they found is amount of input varied, and it varied very much associated with relative socioeconomic advantage. So not only is it affected by socioeconomic advantage, but it's also affected by what you're doing. So some activities are high metrics, like you do a lot of talking when it's visits to families and friends, when it's organised toy play, when it's story time and reading. And it's very low amount of input to the child if it's outside play, if it's screen time, travelling, and obviously nap time or sleep time. We also found that the amount varies according to what the child can hear. So parents were very sensitive to their child having an implant, and whether we measured it in turns or utterances, numbers of words or syllables, we found that after the implant, parents talked more to their child. So we've got pre-implant in the sort of royal blue, and after the implant in the lighter blue. So good to hear that mothers were aware that their child now had a cochlear implant and were talking more. We also found a result which I haven't showed here for prosody. So the mothers used more pitch and stress after the implant as well to gain and maintain the child's auditory attention. So mother's sensitivity and the linguistic cognitive stimulation that's provided has a significant impact on the child's language as age at implant. So addressing parental behaviours is a key target for you out there as habilitationists. It's something we can do, it's something we can change. We can't change the mother's education, we can't change socioeconomic advantage, we can't change the etiology of the child's hearing loss. We can't change if they have an additional cognitive issue or learning disability, but we can change the mother's linguistic stimulation to the child. And this is consistent with Holtzinger, who did a great study of a systematic review and meta-analysis. Basically, the quantity and quality of parental linguistic input was significant had a significant relationship on child language. We're talking about high-level facilitative language techniques, such as parental expansions and open-ended questions. So particular types of language input. Basically, parental involvement had a bit of an effect on parental education, but these were weaker results in the systematic review. This is a good news story for us, though, because we can change parents by improving their high-quality conversations. So this is great news for us because this is a mutable variable or a changeable variable, something we can do something about. The other study that we looked at was using MERLA. So you don't need to read all of these definitions. They're in the appendix of MERLA 2000. I'm happy to share that with anybody. Just take note of the colours. So we've got the parents' participation in early intervention. From yellow, limited in grey, below average yellow, average in green, good in blue, so keep an eye on that one, and red for ideal parent participation in early intervention. And here's the data for some cochlear implant families. Happy to say none of them were rated as a 1. Most of them were in the good and ideal, which is the blue and the red. And what did this matter? Well, when we had a look at parent participation, it explained 23% of the variance in language trajectories. So once again, we've got our lovely tests over time. The average is shown here in the darker blue. Normal for hearing children of 1 year of growth per 1 calendar year is in the dashed black. So parent participation explained more of the variance than age at implant in these data. And if we have just a look at those 2 categories that had the most data, which was the good, parent participation that was good, had child trajectories of 0.75, not quite the magic number 1 that we want. But parent participation that was ideal had a child language trajectory of 1.24. So those differences were significant. So I like to use the term coaching when we're talking with parents. We're not training them. We're not traditional models of therapy. And the reason I like coaching is because it's family-centered. We focus on parent skills. Parent is hands-on, and parent is key to implementation. And us as professionals, as therapists, are in the wings. And I've got some pictures there of kids playing soccer and soccer coaching, and basically the coach isn't out there on the field kicking the balls. The coach is in the wings, and we should be in the wings because we want to empower parents to be the key provider of that language. So I've got a few tips for this, and it's just as simple as where you sit. Here's my table, and here's the child. And it's pretty normal that we put the mother on the child's best side of listening. But where does the therapist sit? Well, if you Google therapy or any image or auditory verbal, you will see the therapist sitting here, all right, on the other side. But that has a problem of divided attention. You're the therapist, not the mother. And you've probably got all these wonderful plastic toys and all these sort of new things that are exciting to the child. So you've created a problem of divided attention. The child doesn't know whether to look at the mother or look at the therapist. So a simple enough thing is just to move to over here. Sitting beside the mother empowers the mother. It means that she is the key person implementing the goals. She is the key person implementing the play. You are the coach and you are in the wings. So back to our question that I proposed, the mother saying, my child has a hearing loss. I should limit what I say, right? She can't hear me talking. I should keep my language short and simple, right? Wrong, okay? So to answer that question and get back to that one, parents need to learn to talk around the clock. And I've got 2 little links there from Rossi, which is Learn to Talk Around the Clock, which is great. And also, I'm sure you've heard of Hannon. So summarising my second trend, parental input. the mother's length, amount of input, the child's involvement in family activities, the parents' participation in early intervention, and the types of parents' linguistic input from the Holtzinger paper, so those facilitative strategies. Those have significant effect. They're significantly correlated with child language outcomes. So my third trend is data logging and language tracking. So I've got a little image there of some data. And we're all getting very used to being the quantified self. We're very used to Fitbits and smartwatches and all sorts of different sensors. Certainly digital cameras are everywhere, the quantified self. So what about wearable digital tracking for children? It's pretty new. There's a high demand and a lot of interest in digital speech analysis. Consumer wearables are on the increase, and you've probably all got one. I've got mine on. We've all got our Fitbits counting our steps for our fitness. They're costly. Not everybody has the same levels of digital health literacy, and they're not used in routine clinical care yet. So quite new. I've got just two examples from our field, and that's data logging, which I'm sure many of you would know about, and the LENA language environment system. Starting with data logging, you probably all know that hearing aids and cochlear implants can count the number of hours that the device is on the child's head, the volume setting and the programs that have been used. It can capture characteristics of the listening environment, such as quiet, noise, and speech in noise. The LENA, some of you will already know about, has the child wears it on a little device tucked inside a special pocket, and it provides information about the language environment. It actually records the whole day of the child, and then the algorithms sort that out into some lovely data that we can use that gives us adult word counts, how many words were said to the child adult turns, and the child vocalizations. The LENA needs to be on the child for 10 or more hours in order for the algorithms to work. It doesn't work if it's only on the child for 1 hour or 2 hours. In a privacy sense, just to point out now, it is recording everything that the child has around them, okay? That data is not necessarily kept. There's two modes where you just have the algorithm for quantity, but it is possible to have that file downloaded for later transcription. Most people just go with the first option, which is let's just count the data and get the numbers out. So why don't we just put a wearable tracker on every single child? What's the risk, right? Well, cost. And cost is not just the cost of the device or the program, but the costs because maybe that money should be spent differently or on a different intervention. The benefits for child language are not clear because there are many other child, family, and environmental factors, as I've gone through today, that might play a role. The privacy, as I said, it's recording you when you go to the supermarket, it's recording you when you're talking to your husband, it's recording everything on the day for that child. It's still not helping those that need it most. So people who are likely to wear devices and trackers and wearable technology are already health literate. They're already probably well resourced, and they're not the people who we really need to help the most. And as yet are not really accounting for user perspectives of acceptability. So we need a lot more work before we just launch into popping one on every child. In data logging, I just want to give it from two perspectives. The person delivering the intervention. It's great for clinicians. You can sort of understand why a child might not be progressing because you can look at the data logging and say, it's not really wearing it more than 1 hour a day. It's consistent with a prevention model, but mostly audiologists and clinicians don't have formal training on how to deliver a bad message. If it's going well, and you can look at data logging and say, 12 hours a day, that's fantastic, as that's what happened with my dad with his hearing aids. The message was good and it was easy to deliver. But how do you deliver a bad message if the mother says, oh yes, little Johnny's wearing his cochlear implant 12 hours a day, and data logging says it's half an hour? What do you do with that? Has technology changed so fast, and yet we haven't caught up with how to counsel this appropriately. Let's look at the person receiving that intervention. Data logging is just an average. Is it accurate? Does it really respect privacy and preferences? Have we always told the families that it's switched on and that these capabilities are there? Do the family feel that they're being interrogated if you don't deliver this message carefully? And the worst possible outcome is that there's a lack of trust, because the mother says it's on for 10 hours and the data says it's on for half an hour. So I think we have a lot of areas to iron out there still. By the way, the WHO definition, World Health Organization, says personal health trackers are about access to your own medical records and might facilitate self-monitoring. You're the one who's most motivated, right? This should equate to family-centeredness, because the parent is the one who spends the most time with the child and is the most motivated. But unfortunately, data logging is not going directly to the family. It goes through a third person. It goes to the audiologist first, and then it's up to the skills of the audiologist or clinician in how you deliver that message. So it's a lot to talk about implementation science, but I'm happy to forward this paper. This is Atkins. It's infinitely dense, this paper. It's very hard to read, but I want to just apply the idea that there are all these categories of framework that data logging is missing, okay? So we don't know enough about it. That's the knowledge domain. We don't have enough about the skills of how to deliver it, whose role is it, and so on and so on. And as I said, I haven't got time to go through implementation science. That's another hour. But just as a framework to think about, are we quite ready for that data logging and how we're delivering that message? The other one is the LENA, okay, which I'd introduced before, and it's from the background of the Hart and Risley work, where we talked about how much talk was in the background for these children, and that varied for socioeconomic. But there was a huge backlash to all of that research and even to the language analysis data. Everybody got sick of blaming the poor parents and for their children's vocabulary. It has this entrenched deficit perspective and tends to blame the impoverished parents for their child's skills. So the other thing about language trackers is it mostly just gives you quantity. It doesn't give you the quality of that input. And if we think back to Holtzinger's meta-analysis and systematic review suggested to us it's the language facilitated strategies. We need to drill down a little bit into those and foster those sorts of language skills, not just say it's down to the parents' socioeconomic background. So once again, introducing Atkins' theoretical framework, I'm suggesting that LENA hasn't quite met all of these domains yet either. So I have a little bit of time, I believe, for future directions. So I'm happy for my group to butt in and tell me how many more minutes I do have left, but I'll forge on.
How much time do you need, Dr. Shani? We can have more than 5 minutes if you need.
Okay, how much time do you think I have?
About 6 to 7 minutes more. Will that be enough?
Perfect. Perfect.
Okay,
I'll do. Tell me when I've done 5. I can see.
Sure.
No, I'm good. I'm good.
Okay, I'll let you know. Thank you so much. But
All
please
right.
go ahead. It's a wonderful presentation with so much of data. We all are very interested, so please go ahead.
Thank you very much. So this is an overview of my future directions at the end of this talk. We've already introduced the idea of implementation science, and I think that is a future direction. We have to be very careful to understand if an intervention is working. If it's not working, change the intervention and be highly critical. And a good understanding of implementation science helps us to do that, to say, where is this intervention falling down? What's not working? Is it at the delivery level? Is it the knowledge? Is it the skills? Is it the understanding of all those different domains, as on the Atkins paper that I introduced you to? The other one that is a future direction is that certainly in the Melbourne program, if the child meets audiological and medical candidacy, the current trend is to bypass a hearing aid trial. And I say that as that's just automatic. That's been happening for years in the Melbourne cochlear implant program. But when I bring this up in other countries, in other contexts, people are still saying, no, we have to try a hearing aid first. So that seems to be a future direction, that certainly in a mature cochlear implant program, we are bypassing the hearing aid trial, just fast-tracking straight to bilateral cochlear implants. And as I said, the average age at implant is now around 11 months in Melbourne. The other future direction is just that there's diversity of early intervention approaches. I don't want to get into the whole argument of oral versus sign versus auditory verbal. I think in the future we will understand a little bit better about how to meet those family choices. And I have a slide that's a bit aggressive about garbage in, garbage out, which I'll show you. And just to end with evidence-based practice. So my next few slides, here's the garbage in, garbage out. And it was attributed to an IBM programmer for programming computers. If you put garbage in the computer, you will get garbage out of the computer. So I'm basically suggesting that a baby's brain is like that. The sensory input in is the hearing. The brain has the task of sorting all that out and making those lovely connections and synapses. And then the output is the child's communication abilities. And garbage in, garbage out applies to speech production, to the child's clarity of speech, and also applies to language. If the child does not have early access to hearing, then they will not have this opportunity for stabilization of vocal, motor, and auditory control. So those auditory feedback loops. It's requisite that the child is intelligible to strangers by 4 years of age. So we need to start early and improve those speech production skills. And garbage in, garbage out also applies to language. If the child has very little input into their brain, which is the computer, then you're going to get very little out. The child needs to be immersed in thousands of hours of natural language. And so here's my swimming pool where we're immersing the child in thousands of hours of meaningful language. My last or nearly last slide is evidence-based practice, and we talk about that a lot and everybody writes it all the time, but what does it actually mean? So I think it's good to sometimes go back to first principles, and it's the conscientious use of the best current evidence to make decisions about patient care. But we can't just forget about the patient. It's actually a three-way. It's research evidence, and not just I know one child who did this, but big studies, 200 kids, 400 kids, 1,000 kids. So pooling the data from the different centres in order to answer questions. It's also your clinical experience and doability. What can I do in my centre that what I can't do? I'd like to do this, but I can't. So it's about clinical expertise. And it's also about the patient values and circumstances. So certainly if the child has additional special needs, learning disability, autism, then you have different sort of set of experiences. So overall, do start early, start young, start cochlear implants at 6 months if your centre has the capabilities to do that. Do measure progress. If the intervention isn't working, change the intervention. And do have a look at implementation science frameworks. I really think that it's complex, but it's a really good way of thinking about intervention. Support parents in highly responsive, relationship-focused interactions. Have a look at Holtzinger, that paper, and have a look at what sorts of language abilities the child should be using and what input, the best possible input from the parent. And collect data, pool data. Get your centres together and have multi-centre studies, because having one little paper of 7 kids or another little paper of 20 kids will not answer these complex questions. So it's continual monitoring, keep revisiting the goals of the child and the family, and it's collaborative goal setting with the child. So the child with hearing loss, like all children, has the right to the best possible input, the most experienced and most knowledgeable clinicians. thank you very much for the opportunity to share these thoughts with you. And there are just a few pages at the end there of some references that I am more than happy to share if anybody wants to email me. Thank you.
Thank you, Dr. Detman. That was an absolutely fantastic presentation. A lot for us to unpack. We have very limited time, so I'm going to rush you through some questions. When you were presenting on the unpacking parental input data, there's a question that's come in, and the question is, were the babies and toddlers included in the study implemented simultaneously or sequentially? And if they were sequentially implanted, then what is the gap between the surgeries, approximately?
Yes, so I don't have that data in front of me, but we did look at, I have a Florida study that I can share if the person would like to email me. So understanding the difference between unilateral, bilateral sequential, and bilateral simultaneous is very complicated. It's complicated because in our data, the children who had unilateral or sequential tended to be implanted in the past and tended to be a bit older. Whereas the children implanted right now, today, if they come along to the implant centre, they would tend to be bilaterally implanted and would tend to be younger. So when you look at the differences between sequential and simultaneous and unilateral, you have those complicating factors of the age of implant and how long they've been using it. So it's not a straightforward thing to answer about the sequentials versus the simultaneouses, those different kids. What I can say is that in our studies, we include everybody. So most of my studies, the only exclusion I have is when I'm looking at age of implant, I have to exclude the children who have a progressive hearing loss, because doesn't make sense to include those. If they had normal hearing and then progressed to profound at age 4 and then had an implant, if I included those in my studies, it would show that it was okay to have an implant at 4. But really the child's language was acquired when they had normal hearing. So my only exclusion is often kiddies with progressive or post-lingual onset of deafness. Other than that, everybody's usually in all my studies. Kids with additional learning disabilities, kids with unilateral, bilateral, sequential, all of them.
Okay.
That was a long answer, sorry.
Well, they can contact you personally if they have more questions.
Yes. There was a presentation that I gave in Florida.
There's another question that's come in. Do you have any data on the progress of children with complex needs?
Definitely, yes. So they represent about 40% of our population. So that's why I like to include them in most of the studies. I've recently just completed a study, it's not published yet, where we looked at the etiologies of hearing loss and we looked at the relationships. So okay, so that's a whole nother study, but I'm happy to share that with people or at another time. Basically, it came down to children with genetic causes or premature birth history or meningitis or genetic syndromic, genetic non-syndromic, what were the other ones? Cochlear and vestibular abnormalities like deformity, things like that. So we looked at all of the etiologies. There were subtle differences between the children who had CMV, cytomegalovirus, and premature birth. Those children overall did more poorly than children who had genetic causes and genetic non-syndromic causes. However, if we just forget about the etiologies, what was more important was whether they did or didn't have an additional cognitive problem. So it was not as simple as saying just the etiology of hearing loss. It definitely came down to cognitive issues. So cognitive delay, cognitive intellectual disability. Yeah. So it's a big proportion of our kids, and it certainly makes a very big difference on language growth.
We're running over time, but I do have one last question that I want to put in, Rashmi, if I may. Yes, talking about pooling data, because Australia definitely takes the lead there. If you could give us 3 tips how do we get people to actually pool data when, for example, especially in your early years, the centers have different protocols?
Yes. So in the JSHLR paper, which I'm happy to share, we pulled data and we in the CLIP. So that's categories of linguistic performance, which I talked about today, and the CAPI. The CAPI is speech perception. So we've got a way of pooling data. We don't care what test you did. We're going to put it all together in a ranking, which is the CAPI-R and the CLIP. And that's in the JSHLR paper. And I'm happy to chat to people about that. That's a good way. That's a good place to start.
Okay, thanks so much for that. And over to you, Rashmi.
We've received a lot of questions for you, Dr. Shani, but due to a paucity of time, we'll probably send them to you on email, and then we could probably, if you would be able to reply. I was told by many not to stop you during the presentation when we were giving you time keeping cues and asking you that we might have only 6 to 7 minutes. So I'm really sorry about that, but
that's all right. I didn't notice any of them. I was talking, but I did think I had an hour. So
it was an interesting presentation with so much of data. It was like a crash course on data and on future directions for us. So thank you so much for the time, and thank you so much for your presentation. I just had one last comment from attendee who has said that it's an awesome presentation, Dr. Shani. Garbage in and garbage out concept is so truly and rightly worded. And there are many more comments and many more questions for you. We'll probably forward them to you on your email. And thank you again so much for taking the time.
It is a bit aggressive. It is a bit aggressive to end with garbage in, garbage out, but it's good to wake you up at the end of a big 1 hour of presentation with something that aggressive.
Thank you so much. Thank you so much for your time.
All right. Thank you very much.
Thank you. That was a wonderful presentation. Thanks. Bye.
Bye.
And now just for some housekeeping tips. So now we will be moving to the audiology room, because we have an integrated session, which is by Dr. Anu Sharma. And now we'll have to move to the audiology room. So I request everybody to move to the audiology room, to the audiology hall. Sorry. Thank you.
Can I just check that you have the link? I only have the link for this session, but do you have the link for the next session?
Yes, we can send you the delegates link, and you could probably, would you like to, I'll just send you the link right now. I'll send you on your email. Is that all right?
That's perfect. Thank you.
I'll send you right now. Yeah.
I'd like to hear Sharma. That would be great.
Yeah, sure. That was an amazing presentation. I'd really like to say that again. It was amazing. Thank you.
Okay. Thank you.
I'll be in touch again. Thanks. Bye.
Bye. And in particular today, I'll talk about this P1 potential. And you can see that here's the response. It's a very large response that comes from the auditory cortex. It's very easy to see in infants and in older children. And we've been able to image it to the primary auditory cortex and the cortical. Have these dark lines represent the normative data, the 95% confidence intervals for normal development of this response. So anything falling between these lines is considered normal. Now, each of these lines here in different colors is a child with cochlear implants. Right after they are hooked up with the implant, you can see that's the first point up here. And you can see how far away from normal they are. So that's how much catching up the brain has to do. And you can see that each one of these lines is a child with cochlear implants. Child after child gets to normal limits, okay? Especially if they're early implanted. And unfortunately, these red lines are children who were implanted after about 6.5, 7 years of age. These are all congenitally deaf children. And you can see there's some change in the red lines, but they never quite get to normal limits. So there is clearly a time-sensitive, a sensitive period. And this is in keeping with, again, the data from the animal, from the deaf white cats, which really influences our work. And, you know, these cats are given a cochlear implant. I don't know if you can see it, but before implantation, there's not much activation. 3 months after implantation, there's a lot of activation you can see, but only a short time later. So for example, about 6 months in a deaf cat's life, if they don't get an implant, then you see very little stimulation. So both the deaf cats and the deaf children tell us that there is a sensitive period early in life, okay, during which about 3.5 years, during which you should put in a cochlear implant. But you don't want to wait that long. You want to get it at the peak of plasticity. And so it's best to implant by age 1 to allow for the most favorable outcomes for children with cochlear implants. Okay, so that's about plasticity, about how the cortex develops. But what about speech and language? Because I was told this session would include people interested in rehabilitation. So I want to talk about language. And I want to thank my colleague Eva Kaltorp in Sweden for this slide. And here you can see this is on this dotted line here is normal development on this test called a RANEL. It's a test of spoken language. And this line here represents children who were implanted about 2 years of age, 2.5 years of age. And you can see that there's a reasonable gap between them and the normally developing children. What about children who get implanted at 18 months of age? There's still a gap, but it's closing in a little bit. You can see in the blue line. Now, what about children who get implanted about a year of age? Watch this. The gap is almost closed in half. And so children implanted earlier within the sensitive period are doing even better on language development. How about children who are implanted about 9 to 11 months of age? You can see there's a little gap to start with, and then that there's catch up very quickly. And what about children who are implanted under 9 months of age? Let's take a look. You can see there's virtually no gap at all. So the earlier the implantation, the better the outcomes for oral, speech, and language development. Okay, so it's not just speech and language. Hearing loss and deafness affects cognitive function as well.
So now we know from new studies coming in, and I believe Karen Gordon is going to be talking about working memory, executive function, attention. All of these are affected by deafness. And so it's really important to not limit our evaluation to simply say speech perception, but we also want to get into cognition and make sure we're looking at things like attention, working memory, executive function, all these skills that the children are going to need in school when they get there. And unfortunately, there are quite a few deficits that children with cochlear implants show in cognitive function. So you can see that they have deficits. Children in cochlear implants are in red here in things like processing speed, attention, working memory, etc. So it's really important to evaluate them. So early implantation and therapy allows for normal cortical connectivity and good neurocognitive outcomes. Okay, so now I want to talk about coming back to cortical auditory evoked potentials. I want to talk about some other populations like auditory neuropathy spectrum disorder. We had a wonderful session in the Global Cafe on auditory neuropathy spectrum disorder, and I believe a summary of that will be presented soon. And as you all know, about 10 to 15% of children with sensory neural hearing loss have auditory neuropathy spectrum disorder, and a much higher percentage, 40% of those that are at risk, so in the NICU, in the neonatal intensive care unit. So here we looked at 21 children with hearing aids who had ANSD and 24 children with cochlear implants. Excuse me. Okay, and what we found is that the children with auditory neuropathy spectrum disorder who had hearing aids fell into 3 distinct groups. So some of them had a normal P1, some of them had a delayed P1, and some of them had a completely abnormal P1. So what does this mean? We further looked at something called intertrial coherence. So this is the amount of phase locking at the cortex, okay? So the thing with auditory neuropathy spectrum disorder, as you all know, is that there is a dyssynchrony. The phase locking at the level of the brainstem is impaired. And so we wanted to check the phase locking at the level of the cortex. And when we looked at children with mild P1, with normal P1, we found that basically the phase locking was okay, not as good as normal, but not too bad. So we classified this as a mild dyssynchrony. When we looked at children who had delayed P1s, it was much less, the phase locking. And so we called it a moderate dyssynchrony. And when we looked at children who had abnormal P1s, we found almost no synchronization, no coherence. So they had a very severe level of dyssynchrony. And this is how we classify children with auditory neuropathy spectrum disorder. What we found is several children who have a normal P1 or a mild dyssynchrony seem to benefit with hearing aids. Although, as we discussed in the cafe, you have to be careful because even though they may benefit initially with hearing aids, down the road, they may need cochlear implants. But what we found is children with delayed P1s or abnormal P1s, meaning moderate to severe dyssynchrony, almost never benefit with hearing aids. Okay, what about the relationship between this P1 response latency and speech and language development? And we found a very strong relationship, a correlation of 0.8. So the more likely your P1 is normal, the better your speech and language development in auditory neuropathy spectrum disorder. Okay, so that was who benefits with hearing aids. Now, who benefits with cochlear implants? So 24 of these children went ahead and got cochlear implants. And what's interesting is, remember, with hearing aids, we had 3 groups: normal, delayed, and abnormal P1s. Well, with cochlear implants, we only saw two groups, normal P1 responses and delayed P1 responses. So no one had abnormal P1 responses with cochlear implants. So everyone is showing some degree of benefit with cochlear implants. So no child with ANSD showed abnormal cortical maturation, at least in this study, those that were wearing cochlear implants. And so cochlear implantation provides some degree of benefit to most children with ANSD. Okay, what about when should you implant children with ANSD? Is it the same sensitive period as with children with children with hearing loss? So let's take a look. So here again is the P1 latency, and this is the normal development, the two dark lines. And here you can see children implanted under 2, the vast majority of them tended to show typically developing responses, but children with ANSD who were implanted after 2 years of age were primarily outside of normal limits, suggesting perhaps a sensitive period of about 2 years for ANSD. So again, we must be aggressive in our rehabilitation and treatment of children with ANSD. Okay, so then the question we want to ask, like Dr. Vanaja is doing, is can we use central auditory system neuroplasticity to help with clinical decision making? And I was so excited to see that she was focusing on clinical acquisition of cortical auditory evoked potential. So I'll tell you how we use it. And so this is the P1 through a hearing aid. This is the P1 through a cochlear implant. We always replicate the waves. And we've looked at hundreds, if not thousands of these children, and we've categorized them into 4 categories. Those that have typical development are on the top here. Those that have an unstimulated pathway, and I know it's an unstimulated pathway by looking at this large negativity that comes before the P1. This tells me this child has never heard. Then I look at a partially stimulated pathway and an abnormal or reorganized pathway. We'll talk more about this. So this is how we do it clinically. So for example, here is a child and I'm seeing a large negativity before the P1. I know this child has never heard. Okay, so this is an unstimulated pathway. When I chart the latency on this left graph here, I can see that it's well outside of normal limits. But look at this, 6 months after hearing aid use, the response shape completely changes. That large negativity is gone. This is an index of maturation. You can see that maturation is taking place. And it's within normal limits, and then it continues to stay within normal limits, and the P1 gets more refined as the child's auditory cortex matures more. Now contrast that with this child who had a hearing aid that was fit for 10 months. Okay, that's a long time in a child's life, and still shows me this negativity suggesting an unstimulated pathway. And then, so the child is a good candidate for a cochlear implant, gets a cochlear implant, and immediately you can see a change in the response at 1 month. You can see a big drop in latency within 6 months, within normal limits, and the response keeps improving. So this is how you can use it. We write a clinical report for every single child so that at a glance you can see whether the P1 is outside of normal limits or within normal limits. We find it most useful for children with multiple disabilities who also have deafness, and these account for about 30 to 40% of the pediatric CI population. So I'll just very quickly show you 2 cases. The first case is of a child with charge syndrome. And here, this is how we do it. This is the audiogram. And it was unreliable, so the audiologist sent the child to us. And you can see a very nice P1 response, so robust, within normal limits. And so we sent this information back to the audiologist, and the child was not really considered a candidate for a cochlear implant. Contrast that with this child who had something called Pallister-Killian syndrome. And this is basically a hydrocephalus that happens. And you can see very nice P1, but outside of normal limits. And they went ahead and put a cochlear implant in this child. And finally, I want to show you some management of auditory neuropathy spectrum disorder. So this is a child who was fit very early with hearing aids at about 0.6 years of age. And you can see the unaided P1 response and the aided P1 response and how it goes from outside of normal to within normal limits. And on this survey of speech and language development, the child is doing very well. And then we have another case where the child was fit with hearing aids very quickly, but showed no benefit. Okay, so you can see a flat line with the hearing aid here, no response, but with the cochlear implant, the P1 looks very strong and is within normal limits. And so this is how we try to use cortical auditory evoked potentials to understand neuroplasticity in individual children and to use it to help guide treatment. So cortical potentials provide useful information regarding clinical management of children with hearing loss who have multiple disabilities and ANST. Okay, so now I'm going to talk about another kind of plasticity, and this is called a compensatory plasticity. So one example of this is compensatory cross-modal plasticity. What does this mean? So for example, in deafness, auditory cortical areas can be recruited by the visual modality, recruited and repurposed by the visual modality for visual processing. Okay, we're going to leave the deaf cats out of this, but we're going to go to deaf humans. In long-term deaf humans, what we see is when we present visual flashes, we can actually see activation of auditory cortical areas. So this is MRI data showing that auditory cortex is active in response to visual stimuli in a long-term deaf adult. And it's not just vision, but somatosensation also recruits auditory cortex in deafness. So you can see that in a normal hearing adult here, this is a dipole. You can see this round circle. When I present a vibrotactile response, a tapping response, I see the activation of somatosensory cortex, post-central gyrus, top of the head here. And in a long-term deaf adult, I see activation of both somatosensory cortex, as expected, and auditory areas. For example, in this case, Wernicke's area, language cortex, is being activated by touch. So this is an example of somatosensory cross-modal plasticity. Okay, those were long-term deaf adults. What about adults who have cochlear implants? And so we know this from many studies. This is a study from Pascal Sandman's lab in Germany that shows that the more cross-modal plasticity by vision, the worse the outcomes in speech with the cochlear implant, okay? However, that's not the whole story, because it appears that there is some real-world benefit to this cross-modal plasticity, in the sense that people who show this cross-modal plasticity by vision actually, even though they have worse speech-only outcomes, they do better in real life. They have better multi-sensory processing outcomes. So that's something to keep in mind. Okay, here's a really nice study that showed that, so they looked at these cortical potentials, and what they found is when they gave adults with cochlear implants and typically hearing adults pictures of houses, they had a very similar cortical response. These are these dotted lines, okay? There was no difference. But when they gave them pictures of faces, adults with cochlear implants showed bigger responses. You can see it in the red. And what's really interesting is these larger responses to faces came from the auditory cortex. So the auditory cortex is being recruited and repurposed for visual processing that's meaningful in adults with cochlear implants, like face processing. And I'm sure you see it in your patients too. So I'd love to hear your anecdotal stories about how you're able to use vision for rehabilitation with your cochlear implant patients. Okay, so that's all about adults, but what about children? So we wanted to study visual cross-modal plasticity in children with cochlear implants. We present some visual stimuli, and then we do some high-density EEG recordings. And what we find is that normal hearing children show activation of occipital cortex, okay, in the back of the head, to visual responses, okay, as expected. But children with cochlear implants, here you can see it, they show additional temporal activation, additional activation of auditory cortex
Hello. Hello, Diksha. Can you hear me?
Hi, Pratibha. I think you're muted. Sorry.
Hello, Diksha. Can you hear me?
Hi, Pratibha. I think you're muted. Sorry.
Hello, Diksha. Can you hear me?
I think you're muted.
Hello, Diksha. Can you hear me?
Good afternoon, everyone. So now we'll be starting the oral paper session in the rehabilitation stream. Sorry about the 2-3 minute delay because the keynote was going on. Now we can start. So a few housekeeping rules. The presentation time is 8 minutes with 2 minutes for question and answers. Please strictly adhere to the timing. At 7 minutes, you will hear a buzzer. You will be told that you have 1 minute remaining. And at 8 minutes, you will hear another buzzer where you would know that your time is over. Please try to finish your slides before that. Do understand that if you do extend your timing, there will be a negative marking. So please take a note of that. Right. So we'll start with the first paper. Dr. Anuradha, you are here, right?
Yes, I'm here.
Yes. All right. So the first paper is by Dr. Anuradha. It's Impact of Lockdown on Internet Addiction, Parent and Peer Attachment and Behavior in Normal Hearing Population and Cochlear Implant Users. Dr. Anuradha, you would want to share your screen now?
Yeah. Will you allow me to do that? Can you see my screen? Is my screen visible?
Yes.
It is visible. Do you want me to switch on the video as well?
Anuradha, just hold on a minute. Just give us a minute. I think there is some rollover from the other platform. Just give us a minute.
Earlier reporting saying that check ESRD in lateral was lateral here. There is a different.
Sorry about that. There was some rollover from the other stream, I think. We're very sorry about that. So now you can start, Dr. Anuradha. You can share, you'll have to go on slideshow and then do it.
Can you see now?
Yes, we can.
Okay. Good evening, everyone. The topic for my presentation is Impact of Lockdown on Internet Addiction, Parent and Peer Attachment, and Child Behavior in Normal Hearing Population and Cochlear Implant Users. So during COVID-19 pandemic, children were compelled to spend majority of the time at their home, which increased the internet use. The negative effect of house confinement were exacerbated by psychosocial stress and lifestyle changes, lack of personal space, thus creating a vicious spiral. Teenagers use the internet excessively or inappropriately to cope with psychological distress and unpleasant feelings related to strained relationships with their parents and classmates. These kind of disease containment measures caused tension within families, impeding family rituals, norms, and values, which can help to control family functioning in the time of crisis. So the aims and objectives of present study were to evaluate internet addiction, parent-peer attachment, and child behavior during lockdown in children with normal hearing, to assess the internet addiction, parent-peer attachment, and child behavior during lockdown in children with using cochlear implants, and to compare the scores of internet addiction test, inventory of parent-peer attachment, and child behavior checklist between normal hearing and cochlear implanted children. The total number of participants was 60 between the age range of 11 to 16 years with a minimum hearing age of 2 years. So there were two groups. Normal hearing were 30 children and cochlear implantee were also 30. They were all attending a mainstream regular school through virtual mode. And children,
just hold on for a second. Sorry, Dr. Pratibha, you mentioned there is some overlap. Could you just tell me what is the overlap? Because here we are not able to see any overlap. Now is it okay? I think at that time it was there because the other hall somehow there was some issue. Could you all, just the others also tell me that now you all have no problem at your ends? All right. Okay.
Yeah,
Seems like there's no problem.
There's
Okay.
no problem.
Thanks, Gina. Thank you so much for that. Yeah. And Dr. Radha will give you 1 extra minute because we did take your time. And thank you for switching on your camera. Yes. All right. So you'll get an extra minute. So sorry about stopping you in between because they were having problems listening to the presentation. So sorry about that.
No, thank you. Shall I continue from here itself?
Yes, no problem. Thank you so much.
So materials and methods, we use 2 questionnaires, that is internet addiction test and inventory of parent-peer attachment, and a checklist which is named as child behavior checklist was administered and responses were recorded. A parent-child interview was taken, which included social demographics, followed by 20 questions that were related to internet addictions, and the responses were recorded on the basis of 5-point Likert scale. The inventory of parent-peer attachment, parent-peer attachment was administered to assess the child's perception of the positive and negative relationships with parents and close friends. And the child behavior checklist consisted of 112 items. Each response was rated on the basis of 3-point scale. So the results. So the first, we compared between the normal hearing children that actually were the internet addicted. So the results showed that 47% of the children had mild degree of internet addiction, followed by 20% Why my voice is echoing? Is it only here? I can hear it, or 20% had a moderate degree.
Fine with your voice, Anuradha. Don't worry.
20% were having a moderate degree of internet use, and 33% fell in the normal hearing category. Then we moved on to checking the cochlear implant users. And to our relief, 73% of them were not having internet addiction, and only 27% of them showed a mild degree of internet addiction. Then moving on to an inventory for parent and peer attachment. To our surprise, both the normal hearing and the cochlear implantees were very well attached to their mothers. So we could see a very minimal difference between the two groups. However, the cochlear implantee children were far more better attached to their fathers as compared to the normal hearing children. So, however, the peer attachment was remarkably affected in both groups. Then we compared both the groups, that is the normal hearing and the cochlear implanted, on internet addiction scale. Obviously, the normal hearing children were having significantly far more addiction than the cochlear implantee. The internet parent-peer attachment scale obviously was not different on the mother's scores. However, the father's scores showed that normal hearing children were significantly below the level compared to the cochlear implantee, and the peer attachment was definitely affected in both the groups. Moving on to the child behavior checklist scores. As you can see that this test has been divided into further subgroups, that is anxiety, withdrawal, somatic complaints, social problems, thought problems, attention problems, rule breaking behaviors, and aggressive behaviors. So we could see that most of the normal hearing children were under some aspects were under clinically significant and quite a few under borderline. So they were having anxiety, rule breaking behaviors, aggressive behaviors almost in 50% of the patients. And then moving on to the cochlear implanted users, they showed more of withdrawal symptoms. They were having social problems. Some of them had a little bit borderline, attention problems. This is where we compared them on a graphical format, but I would like to show you the scores. So the anxiety, as we can see, was far higher in normal hearing children, and that was significantly affected in them. Moving on to social problems, that was somewhere where we saw that cochlear implanted children lagged behind the normal hearing children. And rule breaking behavior was also affected in normal hearing children. I don't know why slides are moving on their own. The rule-breaking behavior was also getting affected far more in normal hearing children, and even the aggressive behavior was seen far more in the normal hearing group. So moving on to the discussion, this study showed that the youngsters with normal hearing are far more addicted to the internet, and the normal hearing children was shown to have internet addiction, which could have resulted in far more behavioral problems. And this has been proven by Bacino et al. In 2019 as well, that internet addiction was connected to loneliness, low self-esteem, depression, anxiety, poorer academic performance, high levels of stress, and mental health difficulty among students. All the cochlear implantee participants stated that far more time was allocated or dedicated to joint activities. As a result, increased family sharing and that family communication improved. This is what probably we saw in the parent attachment scores of the cochlear implantee children. And the peer attachment scores were lower, probably due to the fact that children were unable to communicate because schools were closed and they were unable to participate in outside activities. A similar finding has also been reported by Amakiri et al. In 2020. In terms of attention, withdrawal, anger, and anxiety, both groups exhibited emotional and behavioral changes. The normal hearing group, on the other hand, scored much higher on the measure of anxiety, rule-breaking behavior, and aggressiveness. Previous research have found out that lockdown issues causes tension, frustration, violence, and other issues. And this is also a 2020 study. The cochlear implanting group, however, had social issues which were higher than normal group, which is an area of concern. The overall cochlear implant group had lower scores, indicating that it had less of an impact on their behaviors than normal hearing group. This difference indicates that in some ways, children with cochlear implants are probably more safeguarded and that they are given more quality time. Conclusion, we believe that lengthier periods of social isolation, home confinement, and closures increase the likelihood of psychological distress and development of harmful behaviors in normal hearing as well as cochlear implanted children. As children are considered vulnerable population, it is necessary to lessen the pandemic's mental health impact among these children. These are the references, and if anybody wants to see the scales, so I just put in some points that are there on internet addiction scale, some of the points that are there on the parent-peer attachment scale. However, the child behavior checklist was too long. So like you can see, they have divided among, 7-8 sub-points, and then various questions you have to calculate, and depending on that, you can score them. Thank you.
Thank you, Dr. Anuradha. You have finished well under time. Questions for Dr. Anuradha? We have 2 minutes for question and answers. Ms. Gina,
Yeah, thank you, Anuradha. It was a nice, Dr. Anuradha, it was a nice presentation. I have this one question, like how do you attribute these findings to the COVID? These findings would have been how do you differentiate that this is because of the, COVID situation?
Okay, that's an interesting point because we were also thinking on similar lines. But I just go back a little because we wanted to see this study because when we have a lot of students of speech and hearing, and they came back and complained that, ma'am, our brothers and sisters are showing these kind of problems, internet addiction, they feel less attached to us. They don't even talk to us, forget our parents. So that's when we started wondering that is the COVID or lockdown has led to this impact? And all of them were like, no, ma'am, we feel that it is because of that. The study started from a normal hearing children. We are doing that at large scale. And then suddenly one fine day, we realized that one children came up and said, ma'am, my brother has a stuttering issue. And that has increased far more when the virtual hearing and virtual classes started. That's when it triggered to us that what happens to our cochlear implantee children? Are they actually facing these issues? Are they, having these kind of issues? So that's why we took a normal and control group and we compared their scores, seeing that is there a significant difference between them as well, to show that actually these differences could have been because of the lockdown.
Thank you.
If there are no further questions from the others, we can probably invite the next presenter.
Thank you, everyone.
Thank you so much, Dr. Anuradha. That was a wonderful presentation. Dr. Anuradha, you'll have to, yeah, thanks. The next paper is Perspectives of Parents of Children Implanted under the ADIP scheme by Dr. Aparna Nandurkar. Dr. Aparna Nandurkar, welcome you.
Yeah. Thank you. Can you see the screen?
Yes.
Yeah, just 1 minute. Okay, so sorry. So this is a study titled Perspectives of Parents of Children Implanted under ADIP scheme. Now, the Government of India launched the revised ADIP scheme on 3rd of December 2014 with the main objective of assisting needy children with hearing impairment in procuring a cochlear implant so that their quality of life can be improved. It's important to evaluate the satisfaction of and obtain feedback from the beneficiaries of any CI program and more so of a government-aided scheme, as this will help in identifying the areas that need to be addressed to improve the services as well as to facilitate optimum outcomes. Further, parents are critical evaluators of their child's functioning following any kind of therapeutic intervention. Their perspective is critically important in the assessment of outcomes, as formal objective measures may not reflect the child's functioning in everyday situations like in the home and school environment. Therefore, knowing parental perspectives and obtaining their experiences in a process such as cochlear implantation is really very critical. Now, few attempts have been made to study outcomes and parent perspectives, specifically in children implanted under ADIP scheme. These are some of the studies that I have quoted here. So across all the studies, it is seen that there is a range of outcomes and the parent perspectives also go through a certain range, but overall, the parent satisfaction is good, the parent experiences are very positive, and the children's outcomes are also favorable. So this study we have taken up with the aim of obtaining feedback from the parents of beneficiaries who have completed the stipulated benefits of 3 years under the ADIP scheme and also to study their overall satisfaction. Now, when we look at stipulated benefits being over, we had a total of 486 beneficiaries implanted between December 2014, that is when the scheme started, and December 16. But of these, responses were obtained only from parents of 208 beneficiaries. So the objectives were to obtain parental feedback in these 5 areas: pre-surgery, surgery, post-surgical, care and maintenance, and service and repair, and to obtain the overall parental satisfaction. So we prepared a questionnaire consisting of open and close-ended questions covering various aspects under these areas, and we established content validity, and we collected data through telephonic interviews in the preferred language. All the children fulfill the ADIP criteria, and depending on the ages, the dates between which they were implanted, the hearing age ranged between 3 and 5 years. Data collection and analysis was conducted in a span of 3 months, and this is how the distribution of the parents across the states was. So we can see that bulk of the parents were from Maharashtra, MP, and from the south. Now, coming to the results in pre-surgery, all the parents said that they were provided information about the CI before the surgery. 89% of the children used hearing aid before the surgery for a minimum period of 3 months and also attended therapy before the surgery. The expected outcomes were discussed with most of the parents in the pre-CI counseling, and they were also provided information about provisions under the ADIP scheme. Now, because ADIP scheme does not provide a pre-surgery assessment coverage, 76% of the parents said that they spent a minimum of 30,000 across for this. They were provided information about post-surgery procedures, that is switch-on mapping therapy, and also about the costs involved in the care and maintenance of the implant. Information about the procedure of surgery and the risks involved was provided in detail to 83% of the parents, and 4 of these 208 children had some surgical complications. Now, because these children have already outgrown their benefits from the ADIP scheme, out of these 77% are still attending mapping sessions, 44% still attending therapy, but the others who are not attending, it's mainly because of the distance, the high cost, or because the child has started attending school. And the travel to the therapy center ranges between 50 to 110 kilometers each time. Parents are also provided information about goals and activities to be done at home. When we asked about the listening level of the child, 54% of the children are comprehending complex sentences, 61% have clear speech with an MLU of 5 to 6 words, 92% of them are also attending regular school. 89% of the parents felt that the warranty for the implant and various parts are limited, and 100% feel that the maintenance, service and repair costs are very high. When we look at how they are paying for the repair, servicing and purchase of accessories, it is mostly from their savings, loans from the relatives, bank or help from the trusts. And in case of service and repair, 57% had to repair their processor at least once. Challenges faced are definitely in the areas of expenses involved in care and maintenance and the distance to be traveled to the therapy or the mapping centers. Overall satisfaction rated by the parents, 53% rated between 50 to 75% satisfied and 37% between 75 to 100%. The reasons that are cited here are the challenges that they have reported in the above 5 areas. Suggestions obtained from the parents: warranty period of the implant and accessories must be increased, preferably lifetime warranty. Cost of accessories and servicing to be made affordable by companies. Government should pay for the upgradation of the device, and more therapy centers should be opened in their center in the nearby areas to avoid travel costs. Now, based on these results, it is seen that majority of children implanted under ADIP studied in this study are reported to be improving in auditory, speech and language skills, which is in agreement with previous studies. Biggest challenges are long-term maintenance costs and travel. There is a pressing need to enforce thorough and in-depth pre-CI counseling. All parents unanimously report the scheme to be a boon for the children, providing access to a technology which would have been inaccessible to them. But modifications in the scheme are of utmost importance to ease this entire process for the families. Now, based on the results of this study, already in ADIP, increased warranty has been provided for the processor. We have mobilized resources for providing funds for servicing, repair and upgradation, though in a limited way. We have also been successful in mobilizing grassroots level workers to provide support in habilitation in remote areas. And we have also developed a pre-CI counseling module for the empanel center so that it can be strictly implemented for better preparation of the parents as to what they are really getting into. Thank you.
That was well in time, Dr. Aparna. Thank you. That was just your 7-minute buzzer, actually. Thanks. Yeah. Any questions for Dr. Aparna?
This is Anuradha. I just wanted to know, Dr. Aparna, how did you calculate the MLU?
This is just strictly based on the parent perception. It's a parent feedback. So it is the information is collected from the parents, where we have asked them to give examples of the utterances of the child. This is not directly an outcome study of the children. So we have not gone and tested the children, but what we did is what parents have provided us with the feedback. We have corroborated it with the reports that come to us from the therapy centers every quarter. So it's not that parents have just told what they feel. So when we have asked the parents, now is your child speaking? How clear is his speech? How many, does he speak in simple sentences, complex sentences? How many words does he use per sentence? We have corroborated that because we have data coming from every therapy center every 3 months.
Have you had challenges with downtime and non-users?
Yeah, we have had. Now in this group we have not had, because this is a specific group, very limited group of beneficiaries. They have completed 3 to 5 years. But if we look at other recipients, who have been implanted longer, now the longest is going to be soon 7 years. So we have had problems in basically being non-users because of the challenges that they are facing in, say, for example, we have had children where the processor is not working and it requires repair. But the cost of the repair is like 90,000 or 1 lakh rupees, and they are not able to, especially in COVID, what has happened is many parents lost their jobs. There are no finances available in terms of donations or something. So they are not able to repair the processor. So, for that reason, we have had some non-users. Or other big reason is loss of processor. So we all know that loss of processor is not covered under warranty, So by the time the parents are able to really put up that kind of fund required to get a new processor, the child is not using. So in that case, in that sense, yes, we have had non-users, and we have also had parents where families where they have not been able to really keep up with the required number of therapy sessions. That is again, because of the travel cost, the traveling distance, or again there is loss of wages to the families. They are very poor families, hand to mouth existence. So there are these challenges, definitely.
So it would be like really very difficult to follow up a certain percentage responded. So, but would it be fair to say that if you actually went out theoretically and got access to the people who did not respond to the questionnaire, that's where you might see the real problem?
Yeah, we are in the process of doing that. So we are in the process of, conducting a larger study where, because this is like 208 recipients is nothing as compared to the total corpus of beneficiaries under ADIP scheme so far, So, but of course, the point is, we as an implementing agency, we are not directly dealing with them on a day-to-day basis. We have to depend a lot on the hospitals or the therapy centers, to put us in touch. Like, of course, on the phone and everything, we have been doing video calls and getting videos from the parents, all that we are doing. But still, whatever monitoring is happening is to an extent indirect. But yes, we are in the process of conducting a large scale outcome study, though it is like a retrospective study, but we are in that process. And yes, more challenges will come up when we reach these people.
Thank you so much.
Thank you so much, Dr. Aparna.
Thank you.
We'll invite the next. Sorry. Did somebody want to say something? All right, sorry. We'll go on to the next presentation, which is Association of Cochlear Implant Management Skills of Parents and Outcomes in their Cochlear Implanted Wards, an Indian Perspective, by Dr. Nooreen. Hello, Dr. Nooreen. I think you were not there when we were giving the housekeeping rules. So you will have 8 minutes for your presentation and 2 minutes for the question and answers. At 7 minutes, we will play a buzzer so that you know that you have another minute to wrap up your presentation. And at 8 minutes, we'll have the next buzzer.
Sure. Very good evening. Am I audible?
Yes, you are.
Okay, so just...
and now you can start. Thank you.
Okay, sure. So my title of study is Association of Cochlear Implant Management Skills of Parents and Outcomes in their Cochlear Implanted Wards, an Indian Perspective. So going to the next slide. So parental involvement and self-efficacy are important factors for the differences in children's communication development post-cochlear implantation. It is important that parents are skilled to manage cochlear implant devices appropriately so that their wards may get maximum benefit out of the device. Cochlear implant management skills, that is CIMS self-English, is a 10-item self-administered tool to assess the level of device management skills. The responses are scored from 0, that is never, to 3, that is always, with a maximum score of 51. The total score is converted to a percentage score. A score less than 100% indicates a need for training of the listed skills. So the aim and objective of my study was to translate and adapt CIMS self into Hindi language, to find an association between the CI management skills of parents and outcomes in their implanted wards, to compare pre-post training scores on CMS Self-Hindi and to find out factors affecting these scores. So the authorization was obtained from the author of original questionnaire. Forward and backward method of translation was utilized. It was translated from English to Hindi by a professional translator and a group of 3 ASLPs familiar with both languages. Small changes were permitted so as to adapt the questionnaire to Indian culture. The adapted questionnaire was retro-translated into English by another translator and a group of 3 ASLPs familiar with the both languages. Just a second. So the original and retro-translated English version were compared to ensure no change of the meaning. CMS Self-Hindi was administered on parents of 22 implanted children. The outcome of cochlear implant in the children were assessed using the CAP scale, ISDA scale, and speech intelligibility rating scale and MAGE scale. The internal consistency was tested by re-administering this tool at a time interval of 2 to 4 weeks. The subjects received training of 2 hourly sessions on CI device management skills based on the areas of difficulty as shown by the tool. The tests were re-administered post-training and results were compared. Statistical analysis, Cronbach's alpha was administered to find out the reliability of the test. Paired sample T test was performed to find significant difference between the pre and post device management training. And then Pearson correlation coefficient and ANOVA was performed to find the association between the scores and different variables. Coming to results, here you can see the description of participants. The mean age of the implantees was 7.41 years, and 12 boys and 10 girl implantees were included in the study. Regarding implant models, 16 cochlear, 2 advanced bionics, 1 metal, and 3 digisonic devices were there in the study. Time since initial implantation was 3.36 mean, that is the mean duration. Then mean CAP score was 7.09, mean MAGE score was 29.9, mean SIR, that is speech intelligibility rating scale, was 2.54, and IST, in that we assessed the reception, expression in speech, and that was about 5, that is that was the coding we used, and that corresponds to 13 to 15 months. The retest reliability of the tool, so Cronbach's alpha was used, and we found that it had a high reliability of 0.998. Most of the participants scored below 100% on CMS Self, indicating difficulty with at least one aspect of CI device management. Participants had the most difficulty with the questions relating to program adjustment, and that is 17 parents reported. Then volume adjustment issues and how to put on device, that was issue for 13 parents. So we checked the different factors, how they are going to affect the tools scores. So there was no significant correlation between the tools score and participants' demographic, CI device factors, and clinical outcomes, except MAGE score. A significant correlation was found between the CMS Self-Hindi and MAGE scores. So here we found that no significant correlation means the device management skills do not vary with most of these factors, and there is a need of assessment and training of these skills in this population. The responsiveness of CIMS self-survey was assessed by comparing the pre-training and post-training scores. So you can see in this line graph that, and with the t-test also, paired t-test, we found that the significant difference was found and the scores improved after the training. A client who self-reports difficulty may benefit from consultation if it helps to improve their confidence in CI device management. Many concerns are relatively easy to explain or can be solved easily. Teaching troubleshooting tips. An online education or problem-solving guide may be developed as alternate education tools. Participants showed a significant improvement in the CMS self-Hindi scores following the training, demonstrating that tool is sensitive enough to detect changes in CI device management skills following retraining, and that recipients can recognize improvement in themselves. Training and evaluation of management skills should be part of the rehabilitation process for all cochlear implant recipients. So CIMS self-survey can evaluate CI device management skills among the parents of children with cochlear implants. This tool demonstrated high test reliability, and it can be used to evaluate and re-evaluate CI device management skills at regular intervals and may save clinical time. So this is the tool which we used for the study. Thank you.
Thank you, Dr. Noreen. That was well under 7 minutes. Thank you for keeping to your time. Any questions for Dr. Noreen?
Dr. Noreen, this is Pratibha Dawson from Ramachandra Medical College. Can you please explain the method of your study?
So as I discussed earlier, that we first of all we took this permission from the original authors, and then we translated, adapted it into Hindi language, and then we administered it on the parents of CI children, that is like with at least 1 year of CI usage duration, and then we found that whatever they have reported, like in this area, they are lagging behind, or they feel that they know, but there is some lack, or from 0 to 3, if they have scored like 2, it means they are not fully confident of using that feature in the device, maybe like changing the filters, microphone filters, or like changing programs. So like based on that, yeah.
Yeah, thank you. Sorry to interrupt, but I see a pre and a post training. Was there any training given to them?
Yeah, so 2 early session, this training program was given to these parents, and it was based on the manuals provided in the specific CI device company, and based on that we provided whatever the skills they were lagging behind. On that we gave the training, and afterwards we administered again the whole tool. So that's why there was comparison between pre and post training scores.
So the training materials were not validated. It was used, you used the company's materials.
Yes.
Okay. Thank you. I just wanted to know that.
If there are no more questions for Dr. Noreen. Thank you so much, Dr. Noreen.
Thank you for the opportunity.
May I invite the next presenter, Dr. Rupali Mathur, and her presentation name is Code Switching and Code Mixing in Bilingual Multilingual Children with Cochlear Implant.
Hello.
Dr. Noreen, you need to stop sharing your slides. It's okay, we'll put that right. Dr. Rupali, you can now start sharing.
Yeah. Okay. Can you hear me?
Yes, we can, and you can start now.
Okay. Good evening, everybody. Title of my research paper is Code Switching and Code Mixing in Bilingual Multilingual Children with Cochlear Implant. So, as we know, that studies have proven that learning of multiple language does not hamper overall development of child. And bilingualism is present in almost every country. So when we talk about the bilingualism or multilingualism, the two terms which are inevitable presents are code switching and code mixing. Where code switching refers to the mixing of word, phrases, and sentences from two distinct grammatical subsystems across sentence boundary within the same speech event. While code mixing refers to using two languages, such as a third new code emerges in which elements from the two languages are incorporated into a structure definable pattern. So initially, most of the professionals used to counsel parents of children with hearing loss to focus on only one language. However, in recent years, the scenario has changed. As children with CI, they are able to get more fine phonetic features, high degree of resolution, And they also gain not perfect, but at least incidental and natural language learning can be there. And nowadays, children are receiving cochlear implant at very early ages. So which make it possible for them to learn more than one language. So research also says that children with cochlear implant can learn more than one language. So the need for the study was, as there are very less studies have been done in this area, how multiple language development is happening and what are the factors. And the other point is the occurrence of code switching and code mixing in children with cochlear implant is relatively unexplored, because I have not found any studies. So I thought it will be a good start to at least find out. So aim of the present study was to find out the presence of code switching and code mixing in bi or multilingual children with cochlear implant. So in this study, 12 children participated. Out of them, 9 were bilingual and 3 were multilingual. The inclusion criteria was bilateral severe to profound hearing loss, no additional problem, at least minimum use of 3 years, minimum implant use of 3 years, and they were implanted between the age of 18 to 48 months. And further, we divided these 12 children into the 4 group, because as we know in India, there are many languages. So like group 1 had children, they were knowing Hindi and English. Group 2, children were knowing Gujarati and English. Group 3, Hindi and Gujarati. And group 4, Hindi, Gujarati and English language. So tasks we used, there were 5 tasks. First is the picture naming task. We showed them 30 pictures, random pictures, and they had to name them. The second task was storytelling task. They were asked to describe or narrate a story which is known to them. And further, a picture description task was done. We showed them a garden picture and they had to describe it. And a bilingual family interview was conducted on their family members, which tells about their understanding. There is a expression in the different language known to them. So it was administered on the parents or family members. And the language exposure log was calculated. In that we count like each language, how many hours they were exposed, and further the percentage was calculated. For each language we calculated. So result we will be discussing according to different tasks. First in picture naming task. So this is the graph for group 1, group 2, group 3 and group 4, where green shows English and orange shows Hindi and yellow shows Gujarati. So for the group 1, you can see more of English words. Group 2 also more of English words. And Hindi and Gujarati, they were knowing more of Hindi words. And Hindi, English and Gujarati group, they told also more of English word when they were asked to name. So this could be, like results reveal that children gave name of picture in the language they recall well or use more frequently. Like which word they use more frequently, picture word. And some of them they learned in school and some they used at home and in everyday conversation. However, for few words, most of the children used English names, which we also usually commonly use. So frequency of use of English makes this mental dictionary more accessible, as majority of the formal education is in English language. Many everyday interaction involve English, which leads to words and concept in English become more readily accessible than words in Hindi and Gujarati. And the studies also says the similar thing. Further, in the second task, storytelling and picture description tasks, I am doing it together. Most of them use their mother tongue while narration and use few phrases from English language or used English words in between the sentences. However, few children told the story in English also as they learned in school. So I'm giving one example of IP transcription story by one bilingual child of Hindi and English. So I'll tell you one sentence. The one crow was thirsty. That was English word. If I translate, IP transcription was one crow pyasa tha. So one is the English word, crow is English, and then they're using Hindi, pyasa tha. So like that I have transcribed. And this is another example of picture description which child is using English and Gujarati. So the first sentence, what they told, this is a garden. So they use English and Gujarati together. That is a garden che. A means this. Garden is an English word and che is usually we use in Gujarati for hair, or this is. So for storytelling and picture description tasks, code switching and code mixing was noticed. Linguistic exposure at home and surrounding environment is there in multiple language, as most of us are bi or multilingual and do code switching and code mixing while speaking to children with cochlear implant. We also use many English words while talking in our mother tongue. That can also be the reason for code switching and code mixing. And this, when I will tell the language exposure log result about that, then you can relate it together. Every child was using different code mixing and code switching pattern in the above three tasks. Each child response was unique and different, and it was related to their exposure and proficiency in the language. These findings are coherent with the study by Annamalai and Krishnaswamy. So, result of the bilingual family interview showed for the bilingual family members. So, this is the average score which we got. So, you can see their understanding, speaking, and social interaction was good for the mother tongue. That was the first L1 language, which can be Hindi or Gujarati, and second language is English. So, their proficiency was more in the mother tongue for the family members, and similar was found for the multilingual children also. So this revealed that understanding, speaking ability, and social interaction was better for the mother tongue, L1, compared to second and third language. This also reflects in child's language ability in all the languages. For the language exposure log, the finding of language exposure log said the children were exposed to multiple languages at various situations. For the parents also told they tend to use code switching and mixing while talking with them. So a study by Krishnaswamy revealed that parents of bilingual children usually use mixed language with their children. This is consistent with results of present study. So this is I have made a picture diagram. So you can see the Hindi and Gujarati, which is blue, which is they were exposed to more compared to English. And the similar was in the multilingual CI children. And this is one example how the language exposure log was done. So like you can see morning routine. So first we calculated how many hours the child is awake, and then how many the children languages child here. So morning routine, you can see Gujarati and English together, Gujarati and Hindi. So this is the example. And the further percentage was calculated, how many percentage of the day. So conclusion, result of the present study showed that code switching and code mixing is also present in children with cochlear implant, which is mostly related to the language exposure of various languages and language models in surroundings like parent, teachers, etc. As parents tend to use code mixing and code switching while talking to them. So what can be the clinical implication? So while planning the habilitation goal, the clinician should be aware of the child exposure to different languages at home, school, and other places. And further, the research is needed to find out more detailed analysis of code switching and code mixing, which with respect to their language proficiency. And the future study should also include more language-related issues like approaches in rehabilitation of children with cochlear implant using more than one language, and how the 2 or more language acquisition is occurring in children with cochlear implant. These are the references. Thank you.
Question?
This is Anuradha Bantwal. Rupali, thank you for your presentation. I'd like to know what criteria you used for saying somebody was bilingual or multilingual. How much of that second or third language did they have to have before you said they actually have a language? I mean, they might have a few isolated words, which doesn't make them, which doesn't make you say that they actually speak that language. So what was your criterion?
So it was like they could understand all the three languages. If the child is multilingual, he is able to understand all the three languages, and he can make, if you ask the question, the detailed assessment was not done, but that is a different study which I did previously. So actually like proficiency of different language was also different for them. So like they were more proficient in their mother tongue compared to the other language, but they were able to use at the sentence level all the three languages. However, proficiency was different for the mother tongue as the parents' proficiency was seen.
Thank you. So we've run out of time, so we'll go to the next presenter. May I invite the next presenter, Ms. Himanshi Sharma, and her topic name is Costs and Outcomes of Tele-Rehabilitation and In-Person Rehabilitation for Pediatric Cochlear Implantees in the COVID-19 pandemic era? Welcome, Ms. Himanshi.
Hello, good evening. Thank you. Is my screen visible? Am I audible?
Yes, it is, and you're audible, and your presentation is visible too.
Thank you. So good evening, everyone. The topic of my research is costs and outcomes of tele-rehabilitation and in-person rehabilitation for pediatric cochlear implantees in the COVID-19 pandemic era. So in the pandemic era, something that we all became very familiar to was tele-rehabilitation. Its effectiveness is well documented and abroad, but its use was still very limited in developing countries like India. However, due to the COVID-19 pandemic, there was a shift in trend that was observed among many professionals, wherein more and more shifted to this new mode of therapy, which was tele-rehabilitation. Studies have shown that children with hearing loss do benefit with tele-rehabilitation. Surveys done among SLPs, however, in pandemic time have shown that nearly 50% of them found it to be less effective because they had no prior training. Among the cost studies, studies have shown that tele-rehabilitation was cheaper. There are studies which have documented cost effectiveness of unilateral and bilateral cochlear implantation, but they did not include tele-rehabilitation. Therefore, there's dearth of costs and outcomes studies of tele-rehabilitation over in-person. Scanty research done in West cannot be generalized to the Indian population, especially in the pandemic era, because parents are already facing the economic crisis and are skeptical to adopt new modalities. Therefore, a study providing us evidence regarding costs demanded and benefits provided by tele-rehabilitation versus in-person rehabilitation for CIs was urgently warranted. The aim of the study was to ascertain and compare the out-of-pocket expenditure and rehabilitation outcomes in pediatric cochlear implantees during 1 year of in-person rehabilitation versus 1 year of tele-rehabilitation pre and post the COVID-19 lockdown. So for this, 20 unilaterally cochlear implanted children with a minimum implant age of 1 year were recruited. All the children had taken minimum 1 year of regular in-person speech therapy, and they were shifted to tele-rehabilitation because of the COVID-19 related restrictions. All the participants did not have any associated behavioral issues or structural anomalies. Average age at implantation was 3.5 years. Average hearing age of the participants was 1.3 years during the time of recruitment. And the data was collected at 4 different time points with 3-month interval for 1 year of in-person therapy and 1 year for tele-rehabilitation. Out-of-pocket expenditure, that is the costing incurred by the participants or the parents, were calculated for traveling costs, meal costs, toys, accessories, and internet charges. Therapy outcomes were measured using ISD, MAZE, and RCAP scales. Results of the present study revealed that the average out-of-pocket expenditure during in-person rehabilitation was 8,643 rupees per month, which was higher as compared to the average out-of-pocket expenditure incurred by the participants during tele-rehabilitation, which was 1,466 rupees. So with large cost savings on traveling and boarding, tele-rehabilitation was found to be cheaper. So for the outcome analysis, categories were made in the integrated scales of development, in which category 0 depicted skills that were not appropriate to hearing age, while category 1 and 2 was for skills appropriate for hearing age and those that were beyond the hearing age. Skills category 1 and 2 were desirable and category 0 was undesirable. So here in this graphical representation, we can see the percentage of data points falling in category 1 and 2, which were desirable. And we can see that the percentage of data points has decreased during tele-rehabilitation. That means that the percentage, that means that the progress slowed down during tele-rehabilitation for all the 6 domains of ISD. To look at it differently, we coded the age ranges of ISD into different levels, starting from level 1 to level 11. And we computed the average differences in levels of ISD for 1 year of in-person and 1 year of tele-rehabilitation. As you can see, the numbers, the average improvement during in-person rehabilitation was more as compared to tele-rehabilitation, as you can see it here. However, for cognition and pragmatics, it was the opposite because it depends on the chronological age. These are the line charts which show the maze and CAP scores at various time points during in-person and tele-rehabilitation. We can clearly see that there is progress during both the therapy modalities as the lines are rising, but the sharpness of the slope and hence the rate of progress was slowed down during tele-rehabilitation, which is evident from both the maze and RCAP scores. This table shows the average quarterly increase in score of maze and CAP and the average annual increase in the maze and CAP RCAP scores, which was also found to be lesser during tele-rehabilitation as compared to in-person rehabilitation. Discussion. Tele-rehabilitation was started with limited infrastructure, experience, and training to avoid any lag in the rehabilitation process of the cochlear implantees. The findings of the present study could be attributed to the lesser attention span of children for screen, infrequent mapping visits because of the lockdown, limited accessibility to repair facilities and accessories, decreased social interaction and peer group interaction of children, and also the affected financial conditions of the parents during the economical crisis of the lockdown. Although the rate of progress slowed down during tele-rehabilitation, none of the children regressed. Better cognition and pragmatics outcomes during tele-rehabilitation could be attributed to the fact that these two depend on the chronological age. The lesser cost of tele-rehabilitation makes this modality very acceptable, wherein smaller costs are incurred and cost savings by patient is large. So to conclude, we can say that outcomes of the tele-rehabilitation, although are less, but the cost savings are large, which could encourage the parents to adopt this modality. Tele-rehabilitation was a consequence of a pandemic rather than a favored choice, and it was started with limited infrastructure and training. Therefore, the results of the study were confounded by several factors and cannot be generalized to the normal tele-rehabilitation practice. For a more robust analysis, we must wait for the pandemic situation to get normalized so that the extraneous factors deteriorating the performance in our study are minimized. So for future studies, bigger sample size is recommended, and quality of life, if assessed, would add new horizons to the study. There was an interesting trend of progress, which was positive towards the last follow-up that was observed. Therefore, a long-term follow-up would add new insights to the study. A complete economic evaluation, including the health system cost to calculate incremental cost effectiveness ratio on a larger scale, is underway. We are doing that and we are calculating the health system costs. Thank you for your attention.
Thank you for sticking to your time under 8 minutes. Any questions for Ms. Himanshi?
Himanshi?
Yes, ma'am.
I have a question.
Anuradha, sorry.
I'm not supposed to ask?
Yes, maybe you can ask her later. Okay. Sorry, not right now. First, we'll have to give the time to the judges. Thank you.
Manshi, thank you for your presentation. This is Pratibha. I would like to know the frequency of therapy sessions when you compared in-person and tele sessions, and the duration also.
Yes, ma'am. So for tele-rehabilitation, we stuck to the ISHA guidelines, and the children were given 45-minute session twice a week. And in fact, the frequency of sessions increased during tele-rehabilitation because during face-to-face therapy, patients were coming once in a week or once in fortnight, but these are the results even after that.
So by any chance, do you have any data on the number of attendance the number of sessions they attended via tele and in person? Like you said, they had certain absentees when they were in person, because that would throw a lot of light on when you start comparing both these modes of service delivery.
Ma'am, actually the in-person data I had to collect it retrospectively because the idea of the study, because we started the study after the COVID-19 lockdown. So the in-person was retrospective. So through the progress reports and the older cards of the patients, to the also data collected from their respective clinicians, I could only find out that they were coming once in a week or once in fortnight. The exact number of visits could not be counted. However, for tele-rehabilitation, I had maintained a log.
Thank you, because we have a different experience. That's why I just wanted to know. Thank you again.
Thank you.
If there are no more questions for Ms. Himanshi, we need to move on to the next presentation. Sorry, Ms. Anuradha, if you have any questions, you can probably ask us separately. We are running a bit short of time. Thank you.
No problem. No problem.
Now I would call upon Ms. Roshni Mishra. Her topic name is Co-articulately Measures in the Speech of Pediatric Cochlear Implantees and Typically Developing Normal Hearing Children, a comparative study of locus equation. Ms. Roshni, are you able to share your screen? Ms. Roshni?
Yes, ma'am. I'm just sharing my screen.
Okay, sure. Yes, your screen is visible now, and you will have to go to slideshow.
Yeah,
and then we can begin.
Ma'am, can you see my screen right now? It is on slide share.
No, it's not on slideshow. You need to, your entire presentation along with the panel is visible. So just go to that hourglass symbol down on the extreme right on your screen and then start the presentation. I mean, start the slideshow.
Ma'am, I did the same, but I think so it's not showing the full screen. I don't.
If the judges are fine, can we still go ahead with this? If she's unable to, I think we'll go ahead because we'll have to save time. Yeah, it's okay. Please go ahead.
Okay, ma'am. Thank you. Thank you so much. Good evening, everyone. My research article for the presentation is co-articulatory measures in a speech of pediatric cochlear implantees and typically developing normal hearing children, a comparative study of locus equation. So,
Ms. Roshni, we are not able to hear you. Ms. Roshni? Ms. Roshni?
Co-articulatory effect of a stop consonant on vowel. Locus equation has been used extensively.
Ms. Roshni, we are not able to hear you. I think it's probably something to do with your network connectivity.
Now I'm audible for you, ma'am?
Yes, now it's much better.
Okay. Okay.
Do one thing, can you switch off your video because probably that's taking a lot of your internet bandwidth. So do one thing, you switch off your video so that you can save that bandwidth for the rest of at least. We might have a smoother presentation and we'll be able to hear you then.
Okay, ma'am.
Okay, all right,
Okay.
thank you. Roshni, you will still have to share your presentation.
Yeah. Okay. I'm really sorry, ma'am, for inconvenience.
Now it's on the slideshow. Perfect.
Okay, thank you, ma'am. So what is a locus equation? Locus equations are linear regression of frequency of second form and transition. Sample it its onset, and on the frequency of second form and transition, sample it on the middle of the following vowel for a single consonant co-articulated with a range of vowel.
We'll tell her to log in on the table. We can't.
Miss Roshni?
Ma'am, I don't know. Something has went wrong right now.
Okay.
I'm not able to change my slides.
Okay. Go do one thing. Go back to the initial mode that you had. Maybe your slideshow is a problem. Just open your presentation and share it. Doesn't matter if it's not on a slideshow.
Sure, ma'am.
You have a hotspot, any other connectivity that you can use? If you have any other hotspot, are you using a Wi-Fi? Yeah, just go ahead like this. Doesn't matter. It is better than it getting stuck. Okay, don't worry.
Sure.
Yeah.
Roshni, go ahead. No
Yeah,
problem.
Roshni, go ahead. Yeah.
Therefore, the locus equation represents a particular consonant by following equation. F2 onset is equal to K into F2 midpoint of wall plus C, where K is a slope and C is a y-intercept, and both are constant in a nature. So F2 onset value associated with the release of previous stock, it seemed to vary accordance with the target of F2 on a following vowel. Locus equation, in this way, locus equation enable us to analyze the extent to which the place of articulation of particular stop get influenced by change in a tongue position during the production of following vowel. So my study was aimed to compare the co-articulatory feature evident in a speech of pediatric cochlear implant user with the chronological and hearing aged math children using the local equation perspective. So methodology, 3 group of participants was taken for the study purpose. 3 group of participants was taken for the study purpose. So group 1 consists of 10 CI users, children with a chronological age of 8 to 13 years. Group 2 consists of 10 children with the chronologically aged math children, and group 3 consists of 10 hearing aged math children with the age range of 5 to 8 years. Material used bisyllabic syllables, that is a CBC combination, and targeted syllable was Baba, Dada, Gaga, and Dada. Dada, and V1 was a targeted vowel. So procedure, coming to the procedure, the utterance was digitally recorded on our imitation task on our digital Sony recorder, and then all the recorded utterances was analyzed using the Pratt software. The F2 onset at a first glottal pulse and F2 at midpoint of the vowel, and F2 was extracted using the standard procedure that is given by Sussman et al. In 1991. Statistical analysis. SPSS version 20 was used for the descriptive analysis and locus equation scattered plot. The scattered plot was plotted by treating the F2 onset as a dependent variable and F2 midpoint as an independent variable for all consonants. Kruskal-Wallis test was used for the comparison between the groups. So here is the result for the F2 onset and F2 midpoint for all the age groups, that is a CI children's, hearing age math children, and chronological age math children. So we can look from here for the label Baba, Dada, Dada, and Gaga. So if we are looking for the mean values and a standard deviation, so we can see from this particular table that is as we know that if B, that's a bisyllabic sound, is associated with the so we can get a rising slope, and similar trend it's seen in all the groups of participants, and falling slope for associated with the retroflex, dental, and the wheelers. So similar trends has been observed for all the group of participants. So coming to the scattered plot, this is a scattered plot for all the group of participants. All group of participants for all the bisyllabic sound. That is the first one in the right side, left side for the Baba, and second for the Dada, and third here is for Dada, and next is for Gaga. So there are 3 lines over here. That is a scattered plot. This blue line is for the CI children, and green one for the chronologically aged math children, and yellow one is for hearing for the chronologically aged math children. So if we are looking for the Baba's bisyllabic here, there's as such no much difference between the groups. Same slope is there because R value, if it is nearby to 1, so it's considered having the maximum articulatory effect. If R value is a completely horizontal straight line, that is a 0, so it's considered as having a minimal co-articulatory effect or no co-articulatory effect at all. So if we are looking for all the 4 graphs, so here for the Dada and Dada, if we can look for here, so this green line that is has been used for this slope is for the chronologically age matched children, that is a younger children having an age range of 5 to 8 years. So they having a comparatively better slope. So as this support the holistic theory of co-articulation that says that the comparison to the adult, elder one, and wherever if we are looking for the blue slope, to Baba and Gaga. So here is a regression analysis related parameter for all the group of participants. So we can see that a slope, R square and standard error and y-intercept values over here. So if we are looking for the slope, this is a CI group, this is a hearing aged matched group, and this is a chronologically aged matched group. So for the hearing aged matched group, there's a higher value for the slope, as well as looking for the supported by the y-intercept also. And but when we are looking for the CI and chronological age matched children, there's a no huge difference as such. But if we are doing a visual inspection of this particular chart, so we can look over here that comparatively to the chronological age matched children, still the CI children having a lesser slope value, and similarly for the y-intercept also. So now coming to the discussion, the lesser co-articulatory effect in a pediatric CIE users shows that the children that the transition duration between the syllable structure within the phonotactic syllable shape is not appropriate as comparison to normal hearing children. This compromises the speech intelligibility of CIE children with the course of CIE users. Hence, it plays a vital role to address this issue by opting the co-articulation therapy in an oral rehabilitation program. Conclusion: from the finding of the study, it is evident that the co-articulation plays a vital role in a speech intelligibility for the children with the CIE. Hence, the auditory experience that child revives should be qualitatively high with respect to the segmental and suprasegmental features, because co-articulation happens when the suprasegmental loads is apt on segmental aspects. Thank you.
We just have time for one more question, just one question. If any questions for Roshni. Thank you. If there are no questions. Sorry. Is that you, Pratibha? Do you want to ask something?
Yeah, can I? Yeah.
Sure, please do.
Thank you, Roshni. Just wanted to know these three groups you are comparing. This is one is typically developing children, isn't it? That's what you're saying, chronological age matched. Am I right? You have three groups of children, and one is a CI group, unilateral CI group. The other one is a chronological age matched, which means, are you talking about the typically developing children who have normal hearing?
Yes, that's correct, ma'am.
Okay, so please use the appropriate terms. And hearing aid children, you mean children who wear hearing aids?
No, ma'am. Hearing age matched children means typically developing children who having a similar hearing age. Cochlear implantees hearing age was similar to the typically developing hearing age children.
Okay, so these three groups have come.
These three groups was come. Yes.
Thank you.
Thank you, everyone. At the outset, I would like to thank all the three judges, Ms. Anuradha Bantwal, Ms. Gina Mary Joy, and Ms. Pratibha Dawson. Thank you so much. I know it's been a long day, and thank you so much for taking the time to be here for the oral presentations. I'd also like to thank the presenters. So by this, with this, we announce that today's sessions are closed, and the next oral presentations, remaining ones, would be on Sunday morning. So see you all for the oral presentations on Sunday morning, and tomorrow we will start the sessions at 9 o'clock.
Thank you, Rashmi.
Thank you,
Thank
Roshni.
you for the opportunity for listening.
Thank you.
Thank
Thank you, Rashmi.
Thank you,
Thank you all.
Rashmi.
Thank you all three of you for taking the time.
Thank you.
So much.
Thank you.
Thanks.
Hello.
Yeah, you can stop recording now. Thanks. Recording stopped. Shrikant?
Yes, closing.
Okay, cool. I'll end the session.